need to present it in a chronological order, meaning the complaint which came first, for example, pain in the right hip for the last 3 months and limp in the right lower limb for the past 7 days. So whatever complaint comes first, it should be told first with the number of days or months, and whatever complaint came next comes next. So the presenting complaint has to be very clear and should come with the duration. So normally it is in the patient's own words, and if you take a hip case, the usual complaints in a hip case are pain, swelling, limp, inability to bear weight, limitation of movements, deformity or a limb length discrepancy. Pain is mentioned in the order of occurrence of the chronology I have explained, and then you go ahead describing each complaint on the broad base of onset, duration, and progression. So ODP could be another mnemonic. So history of presenting illness, how do you get it out? You ask the patient, when were you absolutely okay? You actually have to take him back to a place, to a timeline where he was absolutely okay, so that he can actually juggle out and actually tell you the right amount of duration he's been having that illness. And after that, you need to ask him what happened then. But then there would be some patients who would come out with a history, I have been ill for the whole of my life. So you need to be juggling around with these patients, and maybe at times you need to ask them what has brought you to the hospital today, if your problem has been there for ages. So you have to modify your questioning at times, which have to be straightforward, or at times you have to encourage the patient to speak out. So the common complaints around the hip. Now this part we're going to repeat two or three times in the next 10 minutes. Pain, which is going to be the most important. Swelling. Function loss. Now the function loss could be in standing, maybe on both feet or one limb. In walking, it could be in sitting, chair, squatting, or cross-leg, or it could be in lying down. And then the patient could come with a presentation of a deformity. So what do we need to describe about each symptom? We need to describe on the onset, the course, the duration, any treatment taken or given, and what has been the response. So the broad outline for each symptom would be on these grounds. But in pain, there would be certain addition things. We are more interested in understanding what is the exact site, the character, the intensity, and radiation. So normal symptoms, you want to know the onset, and you want to know the duration and the progress. But in pain, you want to know certain more things. So another mnemonic is there to help you, which is by the name of Socrates. So each word means something. S for site, where is the pain? O for onset, when did the pain start? And whether it was sudden, gradual. The character, what is the pain like? Is it stabbing or throbbing or dull aching? Radiation, does the pain radiate anyway? Association, any other sign or symptom which is related to this pain? Time, the course, does the pain follow any time duration? Exacerbation and relieving factors, does anything change the pain? And the last thing, the severity, how bad is the pain? So Socrates is one of the good mnemonic to remember, so that you do not miss out any of the features related to pain. So something more on pain or different perspective. This being the commonest symptom in a hip case, the side, is it left or right, or is it bilateral? In case of bilateral, is it symmetrical, or one side is more painful than the other? The site, where exactly is it? The patient pointing towards the groin, is it on the lateral side, or is it on the gluteal area? The onset, sudden insidious onset, or the patient is not clear on the onset. Duration, and is this duration related to remissions and relapses? The severity, mild, moderate, or severe. The character, dull, sharp, throbbing. Radiation, time, is it continuous? Is it intermittent? Or is it activity related? Is there a diurnal variation? Is night pain a very, very prominent phenomena associated? What are the aggravating factors? Does movement increase the pain? What are the relieving factors? Invariably rest, medication, these are two commonest. Progressive over time. Is pain progressive over time? What is the present status of the pain and what disability is it causing? So the severity, progression, present status, and disability it is causing can objectively be shared from the patient by sharing the visual analog score or asking him to score it from 0 to 10, which will give you some objective idea. It might not be very easy for many patients to come out with it, but if you try it, it gives the clinician a very, very objective way of understanding where he's moving. Now, the side infective disorders like TB hip, septic sequelae invariably are unilateral, inflammatory could be bilateral, AVN if post-traumatic could be unilateral, if it is maybe steroid related, can be bilateral. So all these features are going to take you towards what is the diagnosis in a patient. Site, very important, invariably it is the anteromedial groin plane, which the hip produces. And be careful if it is a gluteal pain. Better check up on the spine and the back and be sure that the pain is coming from where. The next important symptom would be a limp, and we want to know the onset, we want to know the duration, we want to know whether it is painful or painless. Now this one association separates the diagnosis into two groups. A painful limp and a painless limp gives you a different list of diagnoses. And if you broadly divide it, invariably childhood limbs are painless and invariably adulthood limbs are painful. This is a rough sort of a assessment. Progression over time, what sort of a walking does the patient have if he has a limp? Does he need assistance? Is it an assisted gait or he's still continuing unassisted? Or he's just not able to walk? At times, limp could be the first symptom in TB hip even before pain. And as I've already told you, a painless limp is a very, very common presentation in the pediatric. Next symptom, which might not come out from the patient straight away, unless you probe and sort of get it out, if your history is pointing towards such a thing. A swelling, we need to know the side and the side. We need to know the onset in relation to the other symptoms. We need to know the duration, whether it is painful or painless, whether it is associated with a scar or a sinus, and what is the progression over time and what is the present status. So the ODP continues in the various symptoms. So in similar way, history about each symptom should be elicited and noted. And with each symptom, you want to know, and invariably the patient has taken some treatment. So you need to end up each symptom details, description by what treatment he has taken. Like one example I've written down here is that for these complaints, patient took treatment from a local medical practitioner and got treatment in the form of oral medications, tractions, but got only partial relief of his symptoms, so he consulted this hospital 4 days back. So you need to summarize some amount of treatment given with the presenting complaints. Remember, the presenting complaints with a hip case are not going to be many. And then finally, you need to summarize in maybe one line on the current functional status of the patient. One example could be, at present, the patient is walking with the help of walker only at his home. He's unable to attend to his occupation. He's able to sit on a chair, but unable to sit cross-legged or squat. So it gives you a bird's eye picture of what sort of a functional status the patient is having on the basis of history itself. And then the negative history, recent significant trauma, fever, the type of fever, cough, contact with the TB patient, whether the patient has a morning stiffness, whether he has other joints involved. So depending upon the symptomatology, you would like to present a negative history, which will actually support your diagnosis at the end of the day. So next comes is the past history. You want to know something about similar episodes of these symptoms in the past. You want to know any associations of other symptoms, of other systems, whether it is CVS, whether it is respiratory system, whether it is abdominal, and you can just in your mind look for symptoms from head to toe and ask the patient if they might have an association with your presenting complaint. So you want to have a past history of trauma, surgery around the hip, long treatment undertaken, any history of tuberculosis, any dermatological disease for which the patient might have taken steroids, any long hospitalization, or any surgery for any illness. Then comes the social history. It has two parts to it, the personal history and the family history. The social history aids you in the diagnosis as well as discussing the treatment with the patient once you have come to a diagnosis. So in the personal history, again, I will take this quote from William Osler. It is much more important, he says, to know what sort of a patient has a disease. He's assuming that you would know what sort of a disease the patient has, but he emphasizing that you should know what type of a patient you are dealing with. You need to know his personal details, commonly the diet, the alcohol intake, smoking, any other addictions, and females, the menstrual history. The family history of any significant illness in the family or any similar disorder. You have to take a history of tuberculosis contact, any inflammatory arthropathy in the siblings or the parents, any metabolic disorders or hematological disorders. Family history is also important to understand what support system the patient might have to you to decide upon what sort of treatment you can offer him. So you're almost through your history cycle, and be ready with this. The examiner might ask you, or even yourself when you're looking at a patient in a clinic, you want to come to some provisional diagnosis at the end of the history. In an adult, it could be an ankylosis, it could be an arthritis or a synovitis, it could be a post-traumatic situation or any other thing. Without something in your mind. In the exam, you might be asked about, or you might not be asked about what is the causative part of the provisional diagnosis. And I would request, don't jump to a very, very specific, detailed diagnosis on the history base itself. A common diagnosis could be a fibrous ankylosis in an unsound position, maybe an infective etiology. But don't spell out a very, very specific diagnosis, because that is actually not possible with just history. So summarizing at the end, you need to take the patient data, you need to have the presenting complaint very clear with the duration, the history of illness on the onset, duration, and the progression, past history, treatment history, and the social history. So this is a broad plan which I have shared. You might have to add, delete, or change the plan depending upon what case scenario you're dealing with. There would be many other parts which need to be part of your history, which will actually build up during this 2-hour symposium when we're talking about specific case scenarios in the subsequent lectures. One good habit could be, as we make notes whenever we go through any topic we read, most institutes have their own hip performer. You might develop one of your own and then practice your history taking on this, so that it becomes a very, very automatic phenomena for you yourself when you go ahead doing it in the exam. So to end, I would like to share this slide, which is a very, very common practice I do. I divide my OPD's sheet into 4 boxes. The first box is history, the second is examination, the third is investigation, and the fourth is treatment. And that is how we manage our cases, and that is how this symposium is drawn to give you knowledge about a case. Thank you very much.
Thank you, Professor Manny. for a very nice history taking lecture. Now we will take questions for 5 minutes. And is Dr. Vineet? Dr. Vineet?
Dr. Vineet has not yet, sir.
Okay.
Yes.
So,
Yeah, I'm there.
yeah, Dr.
Yes, I'm
Vineet,
there.
please proceed with the
Sir is
question.
there. Sir is there.
In the teaching coordinator, you have any
Can I
questions?
stop my screen share?
Yeah,
Just stop
I
your
could.
screen share.
Yeah,
Dr. Vineet, you are
I'm.
visible, sir.
Yeah, I'm just waiting. Some of my PGs are supposed to give me a call. I'm just waiting for them on the
No,
WhatsApp.
you can discuss. You can ask questions in regard to the postgraduates. You can start asking the questions.
All.
Can I ask a small clarification?
Yes.
Dr.
Yes.
Mani, right? Thanks for very thorough disposition of history taking you have given us. Just very small basic clarification I want about the oldest symptom of the present illness first. Isn't it the other way around that we speak of latest symptom and then go to the oldest of the present illness?
Actually, if you go historically, history is about starting from where the patient was absolutely well. So you ask him, when were you absolutely well? And then you ask him, what went wrong?
Sorry, about the
So
present.
that is what is the convention is. You start with what went wrong, and that is what you sort of label first. I'm not sure whether there are other conventions. There's no big deal about putting it the other way around also. But the convention is whatever symptom has stayed the longest, because that is where the patient starting having his problem. That is where he's answering his
But
question.
presenting
That,
complaints,
what went wrong?
presenting complaints. When you speak of presenting complaints, at that time I was just clarifying.
Yeah.
Okay, and any other question from the panelist? Any other question, or we go to the next lecture? And once I receive questions from the audience, I will keep on asking. So I request now, I think there are no questions at present. So I request Dr. Sudhir Kapoor to come and give his presentation on examination of the hip joint. Dr. Sudhir Kapoor.
PPT visible now? Can you see it?
Yeah, sir, you are visible, sir.
No, my PPT.
No, sir.
Please share your screen.
I thought I shared it.
Sir, please open the PPT separately, then the Zoom.
Okay.
First, minimize the Zoom, sir.
Give me a minute.
Yes, sir.
Minimize, but it's showing in a window separately.
Yeah, sir. And
Now I'm opening the PPT is visible now.
now open the PPT on the desktop, sir.
Yes, I opened the PPT.
Now move to the Zoom
Share with us. Room.
and click the sharing. Share screen.
Okay. Share screen. Okay.
Bottom down.
Is that okay? Fine, sir.
Yeah, got it, sir.
Yeah, now better. Now.
Can you
Yeah,
see
nice.
it now?
Yeah, sir.
Okay, then can I start?
Yeah, sure,
Yes,
sir.
sir. Yes, sir. Please
Ashok,
start.
covered by a lot of pictures. Can we get the faces of the faculty away from there?
Yes,
Sir,
that's better.
you can do it. On the top, there are 4 boxes, multiple
Okay,
windows.
got it.
Just click on the single window, sir.
Okay.
Single window. Single
Okay,
window.
please start.
Okay. Fine, sir. Can I start now?
Yes, sir.
Yes,
Yes,
sir.
sir.
Well, at the outset, I must thank the organizers for this excellent program. And I think Lalit has given a wonderful exposition of history taking. So let me take you to the examination of the hip joint. Well, friend, you must have heard all this thing, that a thorough clean examination is required. Most of the teachers must have told you this. But as far as I am concerned, please understand that sequence is the most essential thing. If you follow a particular sequence throughout your career, throughout your training, you will never miss a finding during the exam. So as far as I am concerned, thorough clean examination, fine. But sequence is the single most important thing as far as I am concerned. Well, there is the sequence is, as you must be seeing on your screens, about inspection, palpation, movements, deformity, measurements, and special tests. I'll proceed according to this plan only. Well, I'll not go into any details of the gait since Dr. Sumit is already covering it. I'll simply, since it is a relevant thing, I'll simply mention these are the important gaits which are pathological gaits which happen in the hip joint disease. I'm not discussing any details, just a few seconds clips with a catch frame for everyone. Now this is a antalgic gait. A gait with a reduced stance face. No further discussion. I think Dr. Sumit will cover it. 10 number gait, lurch on the affected side when it is in the stance phase. Then short limb gait, up and down movements of the on the short limb side when it is in the stance phase. And in a short limb gait, it is not unusual to find one or two elements of pathological gaits combining. Like in this patient, the short limb plus 10 number gait. I don't think I'll discuss anything more about the gait. Now, this 10 number test, the 10 number test sometimes it is included in the special test. But I think it's not a bad idea that before you ask the patient to lie down, to conduct this test to make the thing simpler for the patient and for you also. Now, this is the example of a normal situation when the patient is standing on both the sides. Everything is on the level. The posterior, I mean, you are supposed to examine the patient from the back, appropriately undressed. This is a child, so it is completely dressed, otherwise appropriately undressed. And you are supposed to see the level of the posterior sphenoid spines and the gluteal folds while inspecting from behind. In a normal situation, when the patient stands on one side, the other side posterior sphenoid spine rises a little, and the opposite side gluteal fold also rises a little. This is a normal situation. What happens when there is a abductor weakness because of the hip joint disease? This is what happens when hands on the affected side, the opposite posterior superior iliac spine, instead of going up, it goes down because the abductors are weak on this side. The abductors are weak on the right side. So when the patient stands on the right side, the left-sided posterior superior iliac spine, instead of going up, is going down, and the gluteal fold is also going down. Gluteal bulk or gluteal fold is also going down instead of going up. This is a classical Trendelenburg sign. The next video shows you how to examine a patient with this test. As I told you already, you must examine the patient from the behind. Ask the patient to show his back towards you. Ask him to first stand on the sound limb. This is a normal situation. His left lower limb is normal. That is why the right upper limb, right gluteal fold is going up. Now, once he stands on the right side, the left gluteal fold goes down. The left superior iliac spine tends to go down, and patient lurches on the right side. This is a classical Trendelenburg sign. Now, there is some test called assisted Trendelenburg test. If a patient is unable to stand on single leg stance, the examiner may provide him assistance to stand. Now, this patient has got a weak abductor mechanism on the right side. He is not able to stand on the right side. So we are conducting a assisted Trendelenburg test in this patient. First, he is asked to stand on the normal side, which he is able to do nicely, no problem. The moment we ask him to stand on the affected side, that is the right side, he puts extra weight with the help of his left hand on the patient's right hand, on the clinician's right hand, and only then he is able to stand. Please notice that the patient is putting extra weight on clinician's right hand side with his left hand. This is assisted Trendelenburg test. Now, after we have seen the gait, we have conducted the Trendelenburg test, then we come to the attitude of the limb. We are going as per the plan which I had shown you earlier. Well, one can make out that the limb may be in an abnormal position. You can see that in the In the first picture, the patient's right limb is in external rotation, while on the other picture, the limb is in internal rotation. So attitude of the limb should be noted by the clinician. Now, this is a typical example of attitude of the limb when there is a posterior dislocation of the hip joint. There is flexion, there is adduction and internal rotation. You can see the X-ray of the same patient with the typical attitude of the limb. Now, inspection, once you have done, once you have seen the gait, you have seen the Turnberg sign, you have noted the attitude of the patient. Now come to the inspection on standing from the front. These are all the points which one is supposed to mark when examining the patient while standing from front. I'll give you a clinical example. This is a patient who has got a disease on the right side. Once you are inspecting from the front, make a note whether the head is central or not, whether both the shoulders are on the same level or not. In this patient, right anterior spiritual spine is at a lower level. Right patella is at a lower level. Please make all these observations while inspecting the patient from the front. Then you inspect the patient from the side. On the side, the things which are to be noted are what is the state of the lumbar lordosis as far as the hip joint disease is concerned. Like in this patient, there is increased lumbar lordosis and the right hip and the knee are flexed. As you notice, the patient has been adequately undressed, adequately and decently undressed to examine. Now we go to the inspection from the back in the standing position. Once we are conducting the inspection from the back in standing position, all the points should be properly marked. The posterior spherical spine, the spinous processes, the gluteal bulge, gluteal folds, and the back of the thigh should be visible to you. And you can make these observations, like in this patient, the head is central, both the scapulae and the shoulder are symmetrical, right posterior spherical spine is at a lower level. Now this was the inspection from in the standing position. From that we go to inspection in the supine position. Like in this patient, when the patient is lying down, please make note of the level of the anterior spherical spines on both the sides. In this patient, the right anterior spherical spine is at a lower level, the right lower limb in the external rotation. And similarly, now you can examine you can inspect the patient in the lying down position. When you are inspecting the patient in the lying down position, make sure that the patient is lying on a firm bed with a firm mattress. Make note of you must mark the anterior spherical spine as well as the iliac crest. Make note of any exaggeration in the lumbar lordosis. Make note of the trochanteric region and the lateral thigh mass. This is summary of the inspection. I'm again repeating the points which I have covered. I have told about the gait, then the attitude of the limb, then inspection from the front, from the side, from the back. This will be the summary of inspection. Now comes the palpation. Once you are inspecting, please make note of any redness, any scars, any sinuses, any muscle wasting or any ulcers. Now the different points to be covered, different steps to be done when the palpation is concerned. Palpation is done. The first point, doing palpation anywhere in the body or any system of the medicine is concerning tenderness. As far as the hip joint is concerned, we are concerned basically about the anterior hip joint tenderness. The hip joint tenderness anteriorly is felt or palpated just 1 centimeter below and lateral to the position of the femoral artery. Another type of tenderness which is noticed in patients of hip joint disease is about the bilateral pelvic compression test. We are doing whenever there is a disease which is affecting the central portion of the hip joint, the pelvic compression test will be positive. Now there are other uncommon sites for tenderness pathology. Tenderness in different pathologies of the hip joint. Sometimes there may be a tenderness along the origin of the adductor longus, insertion of the iliac psoas, or there may be the tenderness at the trochanteric bursa, or origin of the hamstrings may be tender at the ischial tuberosity. But basically, we are concerned with anterior hip joint tenderness and bitrochanteric pelvic compression test, which will denote central tenderness. Continuing the palpation further, always palpate the iliac fossa. You may find a cold abscess there, or sometimes in cases of protusio acetobuli, when because of the disease the acetabulum has protruded inside, one may be able to palpate the protruded acetabulum from the iliac fossa if the patient happens to be a thin patient. Now there is something called digital three finger palpation. Though Bryans didn't describe it, sometimes it is known as a digital Bryans triangle. With the help of the three fingers, with the thumb on the anterior superior iliac spine, the index finger on the tip of the trochanter, and the middle finger at the perpendicular going from the anterior superior iliac spine to the floor. This is how the triangle is made, and one is supposed to make triangles on both the sides to compare. One can make out on palpation whether the trochanter has ridden up or not. You must palpate, continuing the palpation further, you must palpate the possible sites of cold abscess, which could be the base of Scarpa's triangle, gluteal lesion, supratrochanteric lesion, iliac fossa, which I have told you already, and anterior medial aspect of the mid-thigh. This is a summary of the palpation. Basically, the tenderness, the local temperature. The tenderness I have told you already. Anterior hip joint tenderness or about the bitrochanteric compression test. You must make a note about the palpation of the trochanter, whether it is hard to touch, whether there is any roughness, or whether there is any crepitus felt during palpation of the trochanter. We have already palpated the femoral artery to locate the point of anterior hip joint tenderness. At the same time, either this test can be done in the last, or at this juncture also you can compare the two femoral pulses and see if the hip joint you are examining, whether it has weak pulses compared to other hip joint. If the hip joint you are examining has either weak or absent femoral pulses, then vascular of Naras is positive. Then I've told you about the distal Bryans triangle, or basically trying to palpate with the help of three fingers and trying to find out whether trochanter has gone up or not. Then I've told you about the sites of palpating cold abscess, and of course tendon sign we have done earlier. Now deformities, assessing the deformities of the hip joint disease is an integral part of the palpation. And to define a fixed deformity in the hip joint would be a fixed deformity is defined as a position of the limb from which it cannot be brought to neutral or zero position for that axis, but further movement in that axis may be possible. For example, if the patient has got a 70 degree of flexion deformity, extension will not be possible, but it may be possible that the patient has got some more flexion beyond 70 degree. This is what is meant by a fixed deformity. Now this is about a person who has got a hip joint which is deformed. A patient cannot walk unless the body compensates. In a case of fixed flexion deformity, the compensation occurs by increased lumbar lordosis. In ambidextrous deformity, the compensation occurs by drop of ipsilateral anterior superior iliac spine and lower lumbar spine scoliosis with ipsilateral convexity. In adduction deformity, there is elevation of the ipsilateral anterior superior iliac spine and scoliosis with contralateral convexity. If you want to measure the exact amount of deformity, one must unmask the true degree of deformity by neutralizing these compensatory mechanisms. That is the basis of assessing deformities in the hip joint disease. Now, fixed flexion deformity can be assessed by the Thomas test. The next video will show you how to do a Thomas test correctly. The patient is lying on a hard bed with a firm mattress. One can inspect and confirm by putting the hand whether the lumbar lordosis is increased or not. Like in this patient is increased, then the opposite hip is flexed. After the hip is flexed to a certain degree, the increased lumbar lordosis starts to obliterate, and at one point it obliterates completely, like in this patient. When this happens, the hip joint goes into the flexion deformity. Confirm by pressing on the thigh whether the limb has gone to exaggerated lumbar lordosis or in the exaggerated flexion deformity, and then measure the exact amount of flexion deformity as shown to you. Every step is important. Now, if you want to know what is the range of flexion in a case of fixed flexion deformity, basically, is there any flexion possible after fixed flexion deformity or not, then this is a method to do this. Please see it carefully. First, the Thomas test is done in the same manner which I have shown to you. The normal hip is flexed. The flexion deformity becomes obvious. Just press to counter for any increased flexion deformity. Measure the flexion deformity. Then with one hand, holding the lower thigh, one can flex the hip further, while with the other hand, one feels any movements of the pelvis. Once the pelvis starts moving, that is the point till which the flexion is present. So like in this patient has a fixed flexion, had a fixed flexion deformity of 60 degree or so, and is almost further flexion is possible till about 80-85 degrees. So he has a free range of about 25 degree or 20 degree of free flexion after the fixed flexion deformity. Now there is a situation called a pseudo flexion deformity. Sometimes the disease is not in the hip joint, but there is a irritating lesion in the vicinity of the hip joint, which is forcing the hip joint into pseudo flexion. Now this is a patient of a pseudo flexion deformity because of a psoas abscess. Now how to differentiate a pseudo flexion deformity from a true flexion deformity? Please see this video carefully. In a case of pseudo flexion deformity, when the disease is not in the hip joint, the rotations will be free and painless. In this patient, rotations are free and painless. If the patient had hip joint disease, the rotations would have been painful. At the same time, in the same patient, if we try to do the Thomas test, the child cries. This is a typical example of a typical case of a pseudo flexion deformity, in which case hip rotations will be free and painless. Now, how to measure if a patient has got a bilateral flexion deformity of the hip joint? How to measure that? This is the classical method. This is a classical method. Okay. The patient is made to lie prone on the examination table. Both the hips are flexed, which will obliterate the lumbar lordosis. Now the one hand remains on the lumbar spine. The other hand extends the hip gradually. At the point where the hip joint, the lumbar lordosis starts reappearing, is the amount of flexion deformity of that particular hip, measured in this manner. The same thing is repeated on the other side. Now this method becomes sometimes impractical if the patient happens to be an adult and heavy. In that situation, I think I have described a new method of testing flexion deformity of the hip joint in cases of when there is a bilateral hip involvement. The patient is made. I think I have not found this method in the literature, and I feel that I'm the first person to describe it. In this patient, in this case, both the hip joints are flexed till the time the lumbar lordosis disappears. The one limb is held by an assistant, while the other limb is gradually extended. At a certain point, the lumbar lordosis starts reappearing. One can measure the flexion deformity in this manner also. The same thing is repeated on the other side. Now, how do you measure a fixed abduction deformity. We are talking about deformities. We have seen how to measure fixed flexion deformity. We have seen what is the normal, what is the range of flexion beyond flexion deformity, and how to measure bilateral flexion deformity of the hip joint. Now we come to the adduction deformity. How do we measure the adduction deformity? As I told you earlier, we have to unmask the deformity. In a case of abduction deformity, unmasking is done in the manner shown. Now this patient has got a abduction deformity on the left side. The deformity is unmasked. The anterior spherical spine was at a lower level. The limb is abducted till the two anterior spherical spine becomes square. And then the amount of abduction deformity can be measured. Now, there is one more method of measuring abduction or adduction deformity by Kothari's angle. In the previous method, which was described by Nelson, also known as Nelson's method, we had to square the limb. While in the method described by Kothari, there is no need for squaring the pelvis. In whatever position the two anterior spherical spines are, one line is drawn to join the two anterior spherical spine. Then a perpendicular is drawn from the anterior spherical spine to the midline, another from the anterior spherical spine of the left side to the midline, as shown in the diagram. In a case of abduction deformity, this will be the below the line joining, so above the line joining the anterior spherical spine. So in this Kothari's method, there is no need to square the pelvis. Same principle is followed. That the anterior spherical spine was on a higher level. The limb is moved to adduction, and the pelvis has become squared now. One can measure the deformity in this manner. So square the pelvis and measure the deformity as shown in the method.
Dr. Sudhir, please be slightly fast.
Okay, dear. Further range of adduction, the same principle as flexion and as in the flexion deformity of the hip joint. Unmask the adduction deformity and see for any further possible adduction. I will not run this video because of paucity of time. Then measure the fixed rotational deformity, which can be gauged by seeing the position of the great toe, direction of the great toe, or by this method in which two lines are drawn. One is a plumb line, another is the line which is towards the roof from the center of the patella. This is a summary of the deformities. Movements we have to see. I'll just make a mention of this Dunham sign. There has been several names for this sign. Basically, this is a sign in which this was classically described in old the slipped capital femoral epiphysis, but it's been described now in AVN also. In which case, when we flex the hip joint, at particular point the flexion stops, and further flexion is possible only if the hip is taken to external rotation. Let us see. Further flexion possible only if the hip is taken into external rotation. Fine. These are all the movements you are supposed to see. These are summary of the movements. Now we come to measurements. Measurement to be true measurements and the apparent measurements. Apparent measurements are in the whatever position the patient is lying. From any central point of the body, we measure till the middle malleolus without squaring the pelvis. In the two length, we square the pelvis by I had shown you the method already by how to square the pelvis. We square the pelvis and then measure the two length. Like in this patient, I'll show you one example only. In a case of abduction deformity, this is the apparent length. it is measured the limb is squared now. And the length is measured. The opposite limb, which was a normal limb, must be taken into similar degree of abduction to measure the two length, which is being done now. Now you measure deformity. I think I'll rush through the rest of the presentation. Now this sign will tell you grossly whether there is a shortening of the limb or not. I mean, the patient lies supine, hip is flexed to 60 degree in the knee, affected to 90 degree, and look for the level of the two knee joints. If there is shortening, the affected knee joint will be at a proximal level. In a case of femoral shortening, a branch triangle is drawn, as I've told you already, by joining these 3 points: anterior sphenic spine, the tip of the greater trochanter, and the anterior sphenic, and the perpendicular is drawn to the bed, and then we measure all the 3 limbs. Like there's a base on the right side, you can see the shortening. This is a method of measuring qualitatively, not quantitatively, qualitatively the supratrochanteric shortening with the help of the Nettles line. The patient lies on the side, the affected side of the hip is limb is the hip and the knee are flexed, and one sees the level of the trochanter, whether it is at the same level of the line joining the anterior spherical spine and the ischial tuberosity. This is a normal situation. In a case with a supratrochanteric, this is another method of seeing whether there is a shoemaker's line, whether the supratrochanteric shortening or no, not. The line joining the typical greater trochanter anterior spherical line is spherical spine is extended further to the midline. If there is a supratrochanteric shortening, these 2 lines will intersect on the opposite side and below the umbilicus. I think I'll leave this. These are a summary of the measurements. These are the special tests. I'll not tell you the details. Only 2 tests are important. This is a telescoping test. If the hip is unstable, this is how the telescoping test is done. And this is about how to measure the hip anteversion. This is the last slide. I mean, you want to see what is the anteversion of the hip joint. The patient is lying supine. The hip is extended and the knee is flexed. In that position, hold from the ankle with one hand, while the other hand palpates the trochanter. Find the position of the limb in which the trochanter is most prominent. In that most prominent position of the trochanter, measure the angle made by axis of the tibia with the perpendicular. This is the angle of anteversion. I think I'll finish here. On the last one, must make a note of the lymphadenopathy and the contralateral hip and knee joint. I think I'll finish here. And basically, I've given you a glimpse of what is the full presentation of the hip joint disease. If anybody is interested, then this is my book is available by CBS Publishers. Thank you so much. Sorry, Manish, if I've taken a lot of time.
No, it's okay, sir. So thank you, Dr. Sudhir. I request Dr. Sumit Surul to be ready with his presentation. And you will get 10 minutes time. By the time you are setting up your screen, I'll just ask some questions from the audience. So one question for Professor Lalit Mani. Dr. Lalit Mani? Dr. Lalit, can you hear me? Dr. Lalit?
1 minute, sir.
Yes.
Yeah, Professor Mani, there is a question from the audience. Now he says that if a patient presents with a complaint of pain 6 months back for 10 days, followed by relief with medication, and an asymptomatic period of 6 months, followed by pain again in similar character and at the same site with no trauma to the site for 1 week, would history of present illness date back to 6 months or start from 1 week?
Johnson says that he was not well 6 months back, and then he had an episode of a problem for a few weeks, got well, and then episode of problem, got well, and then he could have even fallen down and had a significant trauma. But this is where the history is telling us in a very subtle way that probably the disease was there 6 months back with the pain, and then the pathology has caused weakening of the bone and he got a fracture. So according to me, you need to be very clear when were you absolutely fine regarding your hip problem, and that is where your presenting complaint starts.
Professor Manny, there is another question for you. Some history point for inflammatory disease of the hip joint.
Yeah, come again.
Some history point for inflammatory disease of hip joint.
Okay, inflammatory disease. Now, the inflammatory disease could be guided by what inflammatory disease you're looking at. The one major thing is it is invariably a polyarthralgia or a polyarthritis, meaning that more than one joint is involved. So if it is a bilateral hip disease or a hip pain with maybe a knee pain and a shoulder pain, so one history point is any other joint involved. Other is the type of pain. Now, inflammatory pain is going to be different from a mechanical pain. When you are describing a pain, invariably an examiner asks you what type of a pain is it. So basically there could be 3 types of pain. One could be the mechanical pain, the other could be the inflammatory pain, and the third could be the infective pain. So the character of the pain.
Oh.
In infective pain, it could be a throbbing pain. For an inflammatory, it could be a dull aching pain. And for a mechanical pain, it would be stimulated by any movement. So various features in the history would be able to guide you. And one additional factor of morning stiffness gives you a real thump that you're looking at an inflammatory disease.
Okay, thank you, Professor Manny. There is one question we'll take for Dr. Kapoor, Dr. Sudhir Kapoor.
Yes, dear.
Audience wants to know that how to know which pathology is in the, whether the pathology is in the spine or hip in adduction plus scoliosis.
In adduction plus scoliosis.
Yeah, how do you know that it is spine or the hip involvement? Patient has adduction and scoliosis.
Sir, I mean, this is not these are not very separate findings. There will be hundreds of other findings. If there is a hip joint disease. Now, if the scoliosis is because of hip joint disease, he is going to have hip joint tenderness. The movements will be restricted, and you will be able to square the pelvis. I think this there shouldn't be any basically in deciding these.
Okay,
two.
and now
Dr. Manish,
I'll go to
Dr. Manish, one question, my PG wants to know. Can we ask one question, Dr.
Fast,
Sudhir,
because
please?
we are running short of time. If
Dr. Sudhir, very thanks for nice presentation. Only thing we want to know, my PGs are saying, sir, is there any particular order of examination, whether we should examine the patient in lying down first or standing first, or we can do it randomly, because they get confused when the examiner asks you to start the patient presenting. So do we need to?
If you notice, maybe you remember, from the very beginning, I was talking of a sequence, and the very next slide was showing that sequence. We have to go in that particular sequence only. Inspection, palpation, movements, measurements. Inspection. I'll just finish that. Inspection means gait, attitude. Inspection in standing. Inspection in standing from the front, from the side, from the back. Inspection in lying down. And then we come to palpation in that particular sequence.
Yeah, and the only confusion is whether we should examine them in standing first or lying down first. That is the only thing, because patient came walking to you in the OPD.
If the patient has come walking to me, it is standing.
Right.
Can I add to that?
What is clear?
Yeah.
Can I add something?
Yeah.
Yes, please.
Now, this is a known problem that we need to tell gait first or lying down first. So the convention is gait first. However, there are centers which examine lying down first. So the student should be aware that there is another convention also. And if the examiner who is evaluating you wants a different convention, there is nothing wrong about it. And the second point is, if you want to still wriggle out of the situation, is gate first followed by it. There is nothing wrong about the two ways. Since the patient comes walking in the OPD, you do the gate first. If you are doing the lying down position first, you are actually evaluating an inpatient in a hospital. So the convention is gate first, but even the other way around is not a big disaster.
Okay, thank you, Professor.
Oh, thank you. And doing, Dr. Sudhir, one last thing, sir. Dr. Sudhir, doing the measurement in involvement of both the limbs, both the hip joints are involved. How do you measure the length?
Sir, in that particular situation, when the patient has got bilateral involvement, it is almost impossible for anybody, even for the examiner, to really know. It is just a near about thing. You square one by one and then measure, but nobody on the earth, I don't think there's any known method of accurately measuring the true length if both hips are involved. It's become very, very difficult.
Can I add something there?
Yes, please.
So the dictum is, if you cannot put both the limbs in a similar position for measuring, you cannot judge the true length.
Correct. Correct.
Can I add something to this question?
I want to say, Dr. Dhawan, regarding the inflammatory and the mechanical pain, the inflammatory pain will invariably decrease with the movement, and the mechanical or degenerative pains would increase with the movement.
Okay. So I now basically will take questions later on because we are running short of time. So I request Dr. Sumit Sural. Dr. Sumit, please make it by 10 minutes. Just explain about the important dates.
Sure. So thank you so much. And I'm going to talk about a little bit of the normal gait cycle, and then the biomechanics to make you understand how the lurch is on which side, on the affected side. And then I'll talk about a little bit of short limb in towing gait, cane in the opposite hand. If you permit me at this time, then I'll talk about the last two. Otherwise, I'll just stick on to the gait cycle, which starts with the heel strike, then goes onto the foot flat, then is the mid stance, and then the heel off, then the toe off. Then the swing phase starts when the limb is off the ground, starting from the initial swing to the mid swing to the terminal swing. And then the foot again, when it strikes, the heel strikes. That is the finish of the one gait cycle. And one gait cycle consists of 2 steps. So there are other terminologies for this. Instead of heel strike, it is the initial contact. Because, for example, if there's an equinus, the heel will never strike. So it's the initial contact. And what's important is the foot flat. During the foot flat, there's actually a loading response because the body weight is now getting loaded onto the foot and ankle, right? And the mid stance is actually where it's a single limb stance where the opposite limb is off the ground. And this is 40% of the gait cycle, right? So during the mid stance, most of the pathologies get revealed, whether it's the Trendelenburg gait, whether it's the antalgic gait, because in the antalgic gait, the patient will not stand on a single limb stance for a long time because it's painful, right? And we look at, as I said, the single limb stance is only 40% of the 60% complete. If you look at the biomechanics to understand hip pathologies and gait, the biomechanics is taken from the physics levers. The first class lever is where the fulcrum is in between. So the load here is the body weight. And you know that this, to make this balance, so the body weight and the body weight lever arm, this product has to balance with the abductor effort, which is created by the forces of the abductor muscles to balance this, so abductor lever arm. So body weight lever arm and the abductor lever arm, when it matches, then on a single limb stance, this the body is balanced and doesn't lurch anywhere, right? So if we stand on both limbs, right? So what is the distance between the 2 feet? That is around 5 to 10 centimeters. So the body weight, which is around the weight of the head, the trunk, and the upper limb, that consists of about 66% of the body weight, right? The 66% of the body weight is equally divided into 2 hips when the person is standing on both limbs. So around 1/3 body weight on both the hips. Now the moment the person stands on one limb, let's say this limb, then what is happening? This is a the 66% of the body weight plus the weight of this limb. That has to be borne by this or this hip, right? When it's standing on one limb. So that means this body weight is increased. So on standing on one limb, the hip abductor forces have to be much more because this product has to balance this, right? So the hip undergoes a much more pressure, and the abductor forces are much more on standing on one limb. Now, if you look at another aspect of physics, we all know that the center of gravity should pass between the base, right, to make a person stable, right? So center of gravity here is in front of the S2 vertebral body, and that on standing on both limbs is passing in the base, which is the distance between the 2 feet, that is 5 to 10 centimeters. So on standing on 2 feet, the person is pretty stable and he can sway on one side or the other because the center of gravity will fall within this base, which is a 5 to centimeter long distance. But the moment he stands on one limb, so what is happening? So let's look at the center of gravity. Now, instead of the 5 to 10 centimeter, it has become like a cone. So the center of gravity has to pass through this, only through this foot. So if he is going to lurch on the opposite side, the center of gravity will go beyond this. It's like an inverted triangle, inverted cone. The cone is unstable in the pointed here, and more stable if it's the reverse base here. So one is the center of gravity goes away and the patient becomes unstable. The other thing is what's happening. So when he's lurching on this side, so if you see this diagram, when he's lurching on the side, which is his weight bearing, so the body weight lever arm is decreasing. So the product of the body weight and the body weight lever arm is less now. So the abductor forces have to work much less. So in antalgic gait, the abductor forces are less, so the pain becomes less, right? And in Trendelenburg gait also, so when he's lurching on this side, so this the abductor lever arm and the abductors are now able to balance this far better rather than if he was lurching on the opposite side where the body weight lever arm would have increased, right? So in any type of gait, when the person is standing and putting weight on one lower limb, the lurch will always be on the same side on which he's standing. Why? Because the center of gravity has to come here and the body weight lever arm decreases. So this is a more efficacious biomechanics for the hip. So having learned this, let's look at this video where this person is standing on the normal limb. We ask him to stand on the TB hip patient on this side. He's doing a trick movement. I'll explain that later. But we tell him to move this. So now he is, lurched on this side. Lurch means sway of the trunk. So when he is swaying the trunk on this side, what is he doing? So the body weight lever arm is decreasing, right? And the center of gravity is now coming to lie in this small foot compared to if it were on standing on both limbs, it was much wider base, right? So what was he doing by this trick movement of putting weight on the left side? Let's look at it again. So when he asked him to stand on the affected side, this is like putting weight on a cane on the opposite hand, right? So when he was pushing like this on a cane, so the moment, turning moment which is created when he was standing, which was trying to fall the sides, the turning moment is now offloaded by the pushing action, and this pushing action creates a ground reaction force, which helps to, the turning moment is now turned this side, right? So you have because of the ground reaction force, it's the pressure is coming back again. I'll talk about this in the last slide again. So the Trendelenburg gait, Dr. Kapoor had shown very well, is like in other pathologies where affected side, the lurch is always on the affected side. Now let's go to in case of this is a patient with a hip dysplasia. In fact, it's a skeletal dysplasia, multiple joints, and it's got a bilateral Trendelenburg gait. This is known as a waddling gait. So he's waddling like a duck, right? And now we go to antalgic gait. Now the characteristic of antalgic gait is, as I was telling in the normal gait cycle, that the mid stance, where 40% of the cycle, where the entire body weight is being borne on a single limb. So obviously it is going to be painful. So that part of the mid stance phase is going to be much reduced so that the pain is less. And most of the time patient might be taking a double support right? Because he's not having a loading response and a single limb stance, so he takes a double support. And very important is the stride length of the opposite limb that decreases. I'll show it how this happens on opposite in the next video, because here the moment he takes a longer step length on the opposite side, he has to, that means, stand on one limb, which is the affected limb, for a longer time. So that is causing more pain. So he will take a shorter step on the opposite side. And as I discussed earlier, the lurch will always be the same on the same side, because on being on the same side, the body weight lever arm is decreasing. So the product of the body weight and the body weight lever arm is less, and the abductor forces are less, right? So it is less painful. So if you look at this video, it's all double stance, okay? Double support. Now, single limb support mid stance is very short. It's very painful. The active disease of tuberculosis, very short. And which means that he will lift the opposite limb and take a short step, because if he takes a long step, he will have to stand on this painful limb for a longer time, which is very painful. So this side will be short, and the mid stance, obviously, where the entire body weight on a single limb stance is there, is very, very short. And if you look at the lurch, so he's going to lurch on this side, the same side, affected side, right? So next gait is the short limb gait. The short limb gait, as Dr. Kapoor described, is a vertical dip of the shoulder, right? So if you look at a disease where is only pure short limb, for example, there is a malunion of the tibia, right? And the hip is normal. So if he's walking, the hip is normal, biomechanically the joint is okay. So when he puts his on the stance phase, he walks, so the shoulder will come down and the pelvis will come down, okay? But in reality, what happens is that a person with a disease of the hip has got multiple things. He may, because there's a disease in the hip joint, so the disease in the fulcrum, okay, or the lever arm, so the Trendelenburg component will come in. Because it may be painful, antalgic component may come in. So there could be a mixture of everything. So in the exam, some of the examiners like to ask, okay, you tell me, because the candidate starts answering that, okay, this is antalgic also, and this is Trendelenburg also, and short limb also. So some of the examiners like to ask, okay, out of these, which is the most predominant? Like in the video of the antalgic I showed you, the predominant was antalgic, right? In the video of the Trendelenburg, it is purely a Trendelenburg. Now this is a patient again of a hip pathology. You can see the subtle dip of the shoulder, and there is a lurch. So now whether there's a Trendelenburg component, so you give a shoe raise and you compensate the limb length shortening which is there and make him walk, and you find that the vertical dip is less.
Dr. Sumit, please be fast. Dr. Sumit, please be fast.
The component gets revealed, and this sometimes, when we used to do polio surgery, this is where we have to explain to the patient that there's a hip pathology and the shortening. So if we compensate the shortening by limb lengthening, then the Trendelenburg component becomes more, because that gets unmasked now. Because earlier the Trendelenburg lurch was getting masked by the vertical dip. Now the vertical dip is gone, and the entire thing becomes a lurch of Trendelenburg. So another example, vertical dip and a lurch. Okay, Trendelenburg plus short limb, and when we give him shoe raise, the lurch is slightly more. Now this is a case where the limb length discrepancy is very severe, 25 centimeters, imagine, because of the proximal femoral focal deficiency. And we ask the patient to stand. So you can look at the vertical dip there, vertical dip of the shoulder and the pelvis, so unstable. Right? So that is a typical short limb gait, vertical dip downwards.
Dr. Sumit, please summarize now.
Okay, so I can finish. I've talked about the three main this thing. I don't want to go ahead and waste time, because the rest is not so much important. Yeah, thank you.
Sorry, because Acha, there is a very, very good news that our viewership is more than 4,000 today. And we'll first take questions we'll take later on. I request Dr. Maggu to come up with his presentation. Dr. Maggu. Dr. Sumit, stop your screen.
Stop your presentation, please.
It's not minimizing.
stop screen sharing.
Yeah, I'm just doing that. Where is it? Yeah.
We'll take questions at the end. Professor Maggu.
Manish sir,
Yes, sir.
sir, there's a message. The YouTube stream was interrupted in between for a few seconds. It has been started again, sir.
Okay, okay.
For the PGs. Yeah.
Okay. So we have more than 4,000 viewership today and it is increasing. So now I request Dr. Professor Maggu to start with his presentation and you will get 10 minutes, sir. Dr. Maggu. Dr. Maggu, can you hear us? Dr. Maggu?
Can the host unmute him?
He has to unmute himself.
The host can unmute.
Yeah, now, yeah. Am I audible?
Yes, sir. Yes, sir.
Yeah, right. Well, good evening, friends. And the very learned faculty I have with me today, Dr. Manish. Good number, 4,000 participants, very nice. And good topic also for all of you. Now, late presentation, when there is late presentation by more than 3 weeks, this definition will be asked by the examiners of the candidate. Presentation later it is 12 weeks or more. It's called as neglected fracture neck of femur. There is unanimity amongst all the orthopedic surgeons that when we use the term neglected, it is 12 weeks or more. Though in the literature, it could be 4 weeks or 6 weeks or 8 weeks as defined by various authors. When there is neglect in treatment, I again call it a neglected fracture. One is the late or it may cut through. So this is neglecting treatment. I again define it as a neglected fracture. The various problems could be that the neck is absorbed, as you find here. There can be coxa vara, neck shaft angle is reduced, trochanter has gone up. There can be external rotation deformity of the lower limb. Again, you find in this slide, the coxa vara, the trochanter has gone up, and there is shortening of the lower limb. Obviously, you can anticipate. Another problem is when neglect becomes chronic, as you find here, this is an extracapsular fracture of long duration. Patient is walking, there may be another fracture of the neck of the femur. So two fractures. One is trochanteric fracture, other is fracture neck of the femur in the same patient, indicated by the arrows. Here it becomes very obvious because pain becomes more to this patient and there is more of antalgic gait and lurch as well. One can confirm that a second fracture has occurred on CT scan sections as well as 3D reconstruction. So here again you find when metal breaks, so management becomes difficult because removal of the metal is essential to preserve his hip. And don't answer THR in a young adult patient. I'm just advising my postgraduate residents that most of them are now well versed with THR being taken up in various hospitals, particularly corporate sectors. So when the patient is young adult, your answer must be hip preservation. Here the screws are broken, so one has to remove the screws, and that is again a challenge when you design or define the management of such a patient. So here arrow shows you the broken screw, and there is coxa vara also in this patient. This is another problem you find here. Because of the movements of the screw in the head of the femur, there is bone loss, which is again shown to you by these yellow arrows. So once there is bone loss, stability is a very, very difficult question in these cases. You have to preserve the bone. You have to add some bone here to give stability, like fibula or cancellous bone. Only then you can preserve such a hip in a young girl. This girl is only just 21 years old. There is only one classification on neglected fracture neck of femur, and that's also from India, type 1 or group 2 and group 3. When the fracture gap is less than 1 centimeter or head is viable, it is group 1. When the fracture gap is between 1 to 2.5 centimeter, when the gap is more than 2.5 centimeter at the fracture site, I showed you absorption at the fracture site, or there is avascular necrosis, it is group 3. The objective is to achieve pain-free, stable, mobile hip that heals with a vascular head, limb length equalization, and patient should have normal or near normal gait. That's the objective, and that's very important. And that is what you should aim for. Now, closed reduction or open reduction with internal fixation alone, shortening is less than 1.5 centimeter, and femoral head is viable. I'm telling you of a few methods. Or then closed reduction may be difficult. Presence of osteopenia or bone loss when the head is small or there is varus angulation, outcome is unfavorable with osteosynthesis alone. So you have to devise some other method. Now in this country and even now internationally, fibular autograft with the lag screw fixation has become also prominent. There are papers from India by Nagi et al., Professor Yadav, and so many other authors. Union rate is 91 to 95%. It's a biological method. But the problem is of coxa vara. Still, you can find coxa vara in 28% of the patients. There is leg length discrepancy up to 5 centimeter. And again, there is a donor site morbidity. The limb from where you take the fibula, you have to give second incision, and there is morbidity. That is why we say that think of the method which corrects coxa vara, which gives you neck shaft angle, which gives you limb length equalization. In type 3 Sandhu's classification, which I just mentioned, where the fracture gap is more than 2.5 centimeter, or there is avascular necrosis, the failure rate is 67%. So again, this method will not apply to all these patients in group 3. Now, most of the people again still doing this country Maya procedure. The problem is again that union can be achieved in 75% of the patients, but still there is a problem of coxa vara. There is shortening, and limb length discrepancy is there because you, whatever position you have gained on the fracture table, and you have put in your quadratus femoris graft, coxa vara will remain there or will reoccur. Union is 100% when you use vascular fibular graft, but it's a time-consuming procedure. Takes 7 or 8 hours, even 10 hours, and this needs microsurgical facilities, and it is not everybody's cup of tea. You have to have vascular surgeon with you. So this method is not applicable in everybody's hand. Osteotomy have now become popular, I should say. Most of the people, surgeons, have started doing. There are a lot of papers now in the literature also. 3 osteotomies I have described. McMurray osteotomy still being done in this country. Shane's osteotomy still being done in this country. Powell osteotomy now replacing these two procedures. Powell osteotomy is becoming very popular. This is McMillan's osteotomy. It's a medial displacement intertrochanteric osteotomy, the arrow shows. Medial displacement, this is a medial displacement indicated by yellow arrows. Intertrochanteric pelvic support osteotomy. This is, if you define it, the examiner asks you what is McMillan's osteotomy. It's a medial displacement intertrochanteric oblique osteotomy. The weight bearings from sacroiliac joint, because fulcrum is broken to the head, and then directly to the distal fragment. It gives you an armchair type of effect. This is the armchair. If you sit in the chair which has arms, you will not fall. But the pelvic support osteotomy, the weight bearing is directly from the sacroiliac joint to the head and then to the distal fragment. But the side effect is that when you translate the femur medially, you see here, the mechanical axis passes laterally and this results in genu valgum shortening. The disadvantage of McMillan osteotomy is there is shortening of the limb and genu valgum in the long run. So this is a Shan's osteotomy. It is an angular type of osteotomy. McMillan osteotomy is a translation type of osteotomy, but Shan's osteotomy is an angular osteotomy. This is performed at the level of the ischial tuberosity. The distal fragment is abducted. Shan used to give hip spica, but these days we are having contoured plates, or you can contour the plate yourself. The line of weight bearing is very interesting from the side of the pelvis to the proximal fragment and then the femur. McMillan osteotomy, armchair effect, pelvic osteotomy, but this is a angular osteotomy, and the line of weight bearing is from the side of the pelvis to the proximal fragment directly. Again, there is medialization and genu valgum occurs in these patients also. So if somebody asks you the complications of McMillan osteotomy, genu valgum shortening, complication of Shan's osteotomy, again you can say genu valgum in all these patients. Powell said that if you place the fracture surface at right angle to the resultant of body weight forces, the fracture line is compressed. This is conducive to healing and the fracture heals. That's the principle. He too used to give spica. See, fragment is displaced medially under the fracture end. So this too resulted in shortening and stiffness because of hip spica. So now we have better implants, particularly the double angle blade plate or a double angle barrel and DHS plate. You can even use DHS plate. That depends upon your skill. So if you use a double angle barrel plate, some stabilizing implant, when you use it, this medialization can be prevented and genu valgum can be prevented. Limb length equalization can be achieved. That is the beauty of this osteotomy, and that's why the two other osteotomies have always been almost been replaced by Powell osteotomy. So here you find this is 45 degree. We have converted into 25 degree, and this becomes at right angle to the resultant body weight forces, and coxa vara is corrected, and it is conducive for healing. So this corrects coxa vara, this corrects rotational deformities, and a very common movement for all the people, Asians and Indians and third world countries. Patient may be able to squat and sit cross-legged. That is what is the requirement of we people in cases of hip disorders. And if this is a shortening A, if coxa vara you see, the trochanter has gone up, you have to bring it to the center of the level of the head of the femur. This has gone down. So if this is the shortening, A is the shortening, so A plus B is the gain in length by a Powell osteotomy. That's the beauty of this osteotomy, that limb length equalization can be achieved. The two options are left now. THR for elderly people. When a case comes to you, Dr. Mani was telling you that 2 or 3 candidates are given hip cases. And one of them can be fracture neck of femur. If this case is already there in the ward. So your answer in a young adult patient should be Sir, I will preserve the hip. And in a neglected case, the best answer, you can say biological method, say, even you can say, sir, fibrografting. If neck shaft angle is good, you can fix with a screw and put a fibula. But if neck shaft angle is less, you have to correct the coxa also. You think of osteotomy and say answer osteotomy, you will never fail, I can tell you. Surgical technique is very easy. I'm just passing through. Patient maybe on fracture table, but I do it on convention table. So patient on the convention table, just 5 centimeter incision. This is the facial lata. Pass a guide wire. Stabilize the proximal fragment, that's the head fragment with a screw. Because if you pass the blade or the chisel directly, then this head will rotate or wobble. So fix the head with a screw, first with 2K wires or guide wires, then with screw, and now you make a track. And I tell you, for this osteotomy, not much of planning is required. Just excise a wedge of 20 to 30 degree between the two trochanters, greater trochanter and the lesser trochanter. From here, about 15 millimeter distal to the entry of the chisel, because that is the bone block which gives you stability. So see the passage of the chisel both in AP view and in lateral view. That is not difficult to make. This is the frog leg view or the frog leg view. This is the image intensifier, and you just flex it by 40 degree and then externally rotate it and take an AP view. You will see the chisel is in the center of the neck of the femur. It's very important. It may go anteriorly or posteriorly. So must have an AP view and a lateral or a frog leg view. So now you have made a track. Divide the vastus latalis, 2/3 anteriorly, 1/3 posteriorly. And here you are elevating the muscle, but don't disturb the periosteum. And here you have excised the wedge. Distal is in situ. You may use an oscillating saw, or you can also use an osteotome. This is the saw. You can use good chisel also. And the angle between the plate and the femur, just remember it, must be equal to the wedge you have excised. If you have excised a wedge of 30 degree, this angle should be 30 degree between the plate and the femur. And here you have introduced the chisel, and here you have done the fixation. Trochanter has gone down. The good thing is this, that we have not divided the capsule. Approach is Watson-Jones approach. Entry, the track is made, and just push the chisel and the blade after that, and do the osteotomy and abduct the distal fragment, fix it with the screws. So biology is kept intact, capsule is not divided, and this gap will heal. So this is one case of macromedullary osteotomy on one side. This is valgus osteotomy on the other side. This osteotomy was done by my boss 40 years back, and this is a 39 years follow-up, and this is 20 years, 5 months follow-up. Osteotomy done by me in this institution at Rohtak. Now I'm at Max Saqib. And this problem, again, I told you, difficult one, because patient may be just 30, 35 years, totally again not the answer. So you will say, sir, I will remove the implant and I'll preserve the hip, and better method could be an osteotomy or a fibrograph, whatever you think, like, depending upon a particular situation or a particular case which you have seen on examination and taken a history also. So remove the implant, and I have done an osteotomy in this case. I'm not going in detail how did I remove the implant, because that is not your cup of tea. I'm just teaching the methods, narrating the methods, and telling you what are the best procedure in a young adult. So here it is just fixation with the K wire. I have removed the implant and I have done the osteotomy. The same way I have described you, that is a track with chisel, and that is the plate, that is the plate, and that is the wedge I have excised, and this is what you see, the fixation. This is the follow-up at 56 weeks, and patient can squat. You see he's just 35 years male. Don't say, sir, I will do THR. Say, I'll preserve the hip in a young adult. Here, The screws are broken. It's a difficult situation. I'm not going in detail. So if you do Powell's intertrochanteric osteotomy, the highest rate, the union is 92%. Literature says this is between 80% to 94%. Non-union still can occur because of infection, because of implant cut through, because of other reasons. But there is good rate of union if you perform a Powell's osteotomy. If you perform a macular osteotomy, union may not occur. Patient can still walk because of the armchair effect. That is again important point you must keep in mind when you are appearing your examination and going through your viva voce. Limb length equalization can be achieved again. Average shortening in my series is 2 centimeters still because it was excessive to begin with, 5-6 centimeters. Neck shaft angle you can almost equalize and Cox-Savera can be corrected. So some of the result of valgus osteotomy by various authors from this country like Kalra, Sringari and my series and so many other authors by other biological methods like the muscle pedicle bone graft. You see, Bakshi is the pioneer in this country. Now, so many people are doing, but there is only one paper as far as the indexed international journal is concerned on Meyer procedure. That is one only in 1945. There is no other paper on this procedure in the international journals. Powell's osteotomy getting more and more popular for the reason which I have just narrated you and briefed you. So this is a case of, I even do in elderly people. This is just 73 years female because now I have achieved skill. But in an examination, if patient is 73, just say, sir, I will do arthroplasty of any type. Even if you ask, sir, I will do Gurdon stone in a 73, the examiner will be very happy that at least you know the principles. In a young adult, you preserve the hip. In elderly people, you do arthroplasty. So here this result 25 weeks in this lady, 8-year follow-up, just telling you that this is a wonderful procedure and you see how comfortable this lady is sitting, squatting on toes. This is just finishing my first case, 1990. See the follow-up published in Journal of the Trauma, 24 years follow-up. Now, this is a 10 years when she was studying for a master's degree. Now she's 33-year-old, 24 years follow-up. And last month, this is 30 years follow-up. Mild OA changes, and she walks beautifully with no limp. I have made all these lines to draw the various angles, neck shut angle, neck length, and all those things. Just for your understanding, I can have a longer seminar. Even if there is avascular necrosis, it is a biological procedure. And if head is rounded, you can go for this osteotomy. Provided there is no collapse, head has maintained its shape, it is non-union of 18 months duration, it's beautiful. The patient is still working very well after 11 years of follow-up. And I have shown these cases all over the world and can squat.
Dr. Maggu, please summarize.
Now I'm summarizing and just telling osteotomy is a simple procedure, cost-effective, can be performed in a convention center. Union rate is 100% of the osteotomy. Be clear, osteotomy unites 100%. Limp is not always the phenomena. And if it fails, as in this case, 1998, THR can still be done. He was 70 years male, suffering from Parkinsonism. So THR can still be done. So surgical know-how of osteotomy is in danger and being lost. And I have taught you the principles, the various papers. Thank you very much.
Thank you, thank you. Thank you, Professor Maggu. I request Professor Rajesh Malhotra to be ready with his presentation. Professor Malhotra.
Dr. Manish, one question, please.
We can have one question. Professor Malhotra, are you there? Professor Malhotra, please unmute your screen. Shamshul.
I've done that, sir.
Shamshul, please. Professor Malhotra, are you there?
Yeah, I'm there. I have not muted it.
Professor Malhotra, you start your screen share. We can have one question. But Dr. Vineet, you can go ahead with the question.
Dr. Magoo, sir, very good evening and nice presentation. And just tell one thing: is there a particular indication for your McMurray or Belgas osteotomy? Because you have shown one case. On one side, you have got it done by the McMurray, the other side was done by the Belgas osteotomy. What do you say? The indications are remain the same, or is a surgeon's choice?
Yes. And I would say whatever best procedure you can do. If McMurray, you can do skillfully, go for McMurray. If you can do very easily valgus osteotomy using even a double angle barrel plate or DHS, go for that. Limb length can be well equalized with valgus osteotomy. And genovalgum is not the complication in this case if you lateralize the distal fragment. The valgus osteotomy is a better way if there is more of shortening. If there is coxa vera, go for a valgus osteotomy. You can go even for fibro grafting, whatever best you can do, preserve the hip. That's the answer I want to give to the postgraduates as far as examination is concerned.
To take home message that any of the osteotomy can be done for the preservation of the hip. Am I right? For neglected neck.
Your answer should be, sir, I will preserve the hip. Let us be brief. We are teaching postgraduates and residents. I'll preserve the hip. Rata will sacrifice because he is doing it.
Thank you.
Vineet,
Thank you very much. Thank you very much.
Professor Malhotra's presentation, because now our viewership has increased more than 5,000 and there is a very severe pressure of increasing time because we have almost exhausted we are at the end of our 2 hours. So I requested OrthoTV to have a time. But first we go to Professor Malhotra. I request you to give both presentations together. Professor Malhotra.
Sir, please start the slideshow from above, sir.
Dr. Rajesh. Shamshul, please.
Yes, sir. Yes, I've done, sir. Malhotra, sir, can you hear us?
I can hear you.
Sir, you start your presentation, please.
Can you hear me?
Yes, sir.
Then we'll start. So my topic is the evaluation and management of the tubercular hip. And these are the learning objectives as we go one by one about them. So tuberculosis is as old as probably the history of mankind. TB lesions have been found even in the Egyptian mummies and in the old Greco-Roman civilization, and in India it was called as the yakshma. Now, 1/3 of the world population is infected with tuberculosis, active or latent. And between India and China, we have 40% of world's TB cases. Skeletal tuberculosis is 1 to 3% of all cases and 10% of the extrapulmonary TB. The TB hip itself is 15 to 20% of the osteoarticular tuberculosis. Second to spine in a ratio of 10:7. It's common in first 3 decades and it is more common in males. Let's talk about the microbiology. So we have Mycobacterium tuberculosis, which is the thin rod with round ends. It's about 2 to 2.5 micron long. It's non-motile, non-capsulated, and it's acid fast. The Mycobacterium africum is common in the continent, and Mycobacterium bovis is prominent in the places where milk is not pasteurized. And then we have the Mycobacterium avis, which is seen in the immunocompromised patients. It's a strict arrow, grows in the enriched LJ media. It is very slow growing, takes about 4 to 6 weeks to grow. And you can detect it faster with a liquid media with radiometric growth called BACTAC. It can be available in 1 to 2 weeks. Now about the pathophysiology and pathogenesis, it always starts with a primary focus, which could be active or latent. And it usually takes about 2 to 3 years for that primary focus to cause a hematogenous spread, and then it spreads to the joint or the bone and causes osteoarticular tuberculosis. So bacilli can reach the joint space either through the synovium, that's a synovial focus, which has a protracted slow-growing course, or it can be epiphysis or metaphysis, which is an osseous focus, which is quite common in the hip. Now, the hypertrophy of the synovium and congestion causes the effusion. The thickened tissue with inflammatory infiltrate spreads as spanners, causes erosion and destruction. There are flakes of necrosed articular cartilage called the rice bodies in the joint. And then the effective chemotherapy leads to thickened fibrotic tissue and granulation tissue and may lead to fibrous ankylosis. The osseous focus is common in metaphysis in children and in the ends of the bones in adults. Radiologically, you see the local destruction and marked demineralization. You would remember that the juxta-articular osteoporosis is seen in rheumatoid arthritis and tuberculosis as two typical conditions. And then the metaphyseal lesions can infect the joint space. It involves the subarachnoid space, joint capsule, and can lead to destruction of the epiphysis. So this is typically the diagram you should remember. The acetabular roof is the most common site, followed by the femoral head or epiphysis, followed by the femoral neck, and then the greater trochanter. Now, the cold abscess can be because of exudative reaction. It consists of white blood cells, serum, caseous material, bone debris, bacilli, etc. It penetrates the ligament and through the various facial planes may track into the various potential areas, spaces around the hip joint. Now, let's talk about the natural history of the disease. So, in untreated cases, the disease of hip joint passes through different stages, which are as follows. The first one is a tubercular synovitis, early arthritis, advanced arthritis, and then advanced arthritis with subluxation or dislocation. Now, the stage of synovitis leads to apparent lengthening and the flexion, abduction, external rotation deformity. The stage of early arthritis causes apparent shortening with the deformity of flexion, adduction, and internal rotation. The stage of advanced arthritis causes true shortening with the same deformities with shortening, and the stage of advanced arthritis with dislocation causes true shortening with dislocation of the hip joint. Now, the stages of the tuberculosis, this is how they look on the radiological picture, just for you to see the degree and the extent to which it progresses. The clinical features consist of classical, like I said, the first 3 decades are the commonmost age group. There is often a history of contact, but it may not be there. Presenting symptoms have been described very nicely by Dr. Lalit Mani for any hip disease. So you'll have all those. The pain can be insidious. It could be mild or intermittent. The typical thing about tubercular joint involvement is night cries. During the daytime, the muscle spasm keeps the damaged ends of the bones away. When the patient sleeps, the muscles relax and the damaged bone ends come together and cause severe pain, and the patient gets up with severe pain and cries. Radiation to groin is common, and the pain is often increased at the end of the day. There can be constitutional symptoms like fever, anorexia, weight loss, malaise, and fatigue, though you can see tubercular involvement of the joint without these features. The limp is early stages is because of the stiffness and flexion deformity, which causes the body to bend forward. When disease progresses, the patient gets a limp due to pain from the rubbing together of the damaged bone ends, which are denuded of the cartilage. And in advanced stages, the limp is because of the true shortening. And this is actually the video which is supposed to show you the limp in a patient with tubercular arthritis, which is actually, you can see it's quite marked. The examination shows wasting of muscles, joint line tenderness. In a hip joint, it will be in the front, on the side, or on the back. The deformity depends on the state. Attempted movements cause pain and spasm. There's global reduction of range of motion when the hip becomes arthritic. There could be inguinal lymphadenopathy, or there could be sinus fistula or cold abscess, though we don't see it very common now. This is a picture showing the wasting of the thigh muscles on the affected side. This is showing you the flexion deformity of the hip, and this is showing you the adduction deformity, and you can see the pelvis is not square. On the affected side, which is the left side, the ASIS is at a higher level, which you can square, get the joining ASIS perpendicular to body axis by adducting and putting it in the position of deformity, as Dr. Kapoor told you. The radiological finding consists of the Femister triad, which includes the juxta-articular osteoporosis, peripheral erosions in non-weight-bearing areas of the joint, and gradual joint space narrowing. Most commonly, it's a monoarthritis, and fibrous ankylosis is more common than bony ankylosis, and reactive bone formation is not seen. That's how you can differentiate it from the pyogenic arthritis. This is the Shanmuga Sundaram radiological classification of tuberculosis. So the first is the normal type, which is minimal disease, only synovial disease without any subchondral involvement. Then is the traveling acetabulum type, where there's a destruction of bony acetabulum and weight-bearing part of the acetabulum is eroded and the femoral head migrates. Then there is the dislocating type, where the partially dislocating head with the adductor spasm, and the capsule is weakened and ruptured by chronic inflammation, giving rise to the dislocating type. The Perthes type is superiolateral disease with destruction of the head. You can have the presence of cyst and acetabular osteopenia. If you look at it, it looks quite like a Perthes disease. Then the protrusio acetabular type, which is where there's a softening of the medial wall of the acetabulum, and that gives rise to a protrusio type. And then there's an atrophic type, which is a stage of destruction when the disease burns out due to minimal infection. And you see this is the kind of picture. And then the mortar and pestle, where there's a gross destruction of the head and acetabulum acquires a saucer-like shape. There's a paper in IGO where the author Dr. Anil Agarwal et al. Have described an unclassified type, which is essentially, according to them, the triradiate involvement of the primary the disease, where the focus is really there. Now, these have also been linked to the results. So the good results are seen in 92% of normal type, 80% of Perthes type, 50% of dislocated type, and 29% of traveling acetabulum type. And if the joint space is reduced to 3 millimeter or less, then the outcome is poor. About the diagnosis and the diagnostic test, the direct diagnosis is possible by a smear looking for this staining for AFB. You can see it if there are more than 10 bacilli per cubic millimeter. That's very unusual because we know that the osteoarticular tuberculosis is a pauciarticular, paucibacillary kind of disease. So it is very uncommon to find the bacteria, and still many centers, particularly when they don't have many facility, would like to aspirate the joint and subject it to the smear. The culture in the LJ medium, like I said, the backtech, which gives you the earlier diagnosis, the histopathology shows caseous necrosis with granuloma formation, and then molecular diagnostics like NAAT, PCR, and they are actually highly specific types. The smear microscopy is more for an associated lung lesion. Like I said, it's a less sensitive technique. And, you know, if you have a sputum, you ask the patient to come twice, which is a difficulty. And it is only used in the absence of better alternatives. Culture, of course, is a gold standard, but then it is got sensitivity of only 30 to 80%. But the bigger problem is that it takes very long, and the specificity is about 100%. And like I said, you have automated liquid culture system. It can give you slightly quicker diagnosis. Gene Expert, like I said, is a fully automated diagnostic molecular test using nucleic acid amplification. It simultaneously detects the tuberculosis and rifampicin drug resistance, which is because of the RPO-B gene, and its use has been encouraged under the Expand TB initiative. And the indirect diagnosis, like tuberculin skin tests, are not very specific. It's a delayed type hypersensitivity. Its more importance lies in a negative reaction in immunocompetent patient, which almost rules out the diagnosis. And then the ESR and CRP are not very reliable, but can be used to assist in the diagnosis. Now, you can also look at the sensitivity of the drug. And then there are two ways, which is the DST and the line probe assays. The broad ways to test the drug resistance or sensitivity is one is the phenotypic and the second is the genotypic. Now, in the phenotypic, there are two models. One is you inoculate the specimen on two media. One has got the drug, the other one doesn't have a drug. So if the drug is able to inhibit the growth of the bacteria, then it means that it is sensitive to that drug. The other method is indirect, which is actually the gold standard, where actually the specimen is grown in a culture to a significant sizable volume, and then the testing is done on that. Of course, this takes a much longer time. The genotypic type of tests are the molecular tests which aim at detecting the gene mutations responsible for drug resistance. So there are two main types of genotypic assays. The Beacon assay, which is the Gene Expert, which can give you an idea about the rifampicin resistance. And if you have that, then you are well advised to go for line probe assay, which is actually detects the SNPs and the direct mutations, which can tell you about the INH resistance as well. About the treatment, the aims of the treatment are to cure the patient and restore the quality of life and productivity, to prevent the late effects of osteoarthritis of the joint, to prevent relapse, and to prevent the development of the drug resistance. The chemotherapy is the mainstay of the treatment. There's no universal consensus on therapeutic guidelines. I'll give you what is mostly agreed upon, and the treatment can be classified into drug sensitive and drug resistant. So these are the first line drugs and their daily dosages. All of you must know that. Remember, not only that, but also the mechanism of action and the contraindications, which is very important. And you can be asked in the exam, and it's really a crime not to know your antitubercular drugs very well. And then there are second drugs which are used for MDR TB, which can be some of the first line oral drugs. It can be injectable, it can be fluoroquinolines, it can be oral bacteriostatic drugs, which are second line agents and agents with unclear role, and you must be conversant with these as well. The index TB guidelines say that for most of the stages, you have to give 2 months of 4-drug regime, which is the rifampicin, INH, pyrazinamide, and ethambutol, followed by 10 to 16 months of 3 drugs, which is rifampicin, INH, and ethambutol. And this is an 18-month course. And you can see that in these guidelines, the rest of the recommendations are about the specific treatment for the joint, but the chemotherapy is almost the standard for this. Now, general principles for MDR TB are that you have to use at least 4 drugs. Many times you have to use more than 4 drugs. It should be based on the drug susceptibility test pattern. And then, of course, you must include drugs from group 1 to 5 in hierarchical order and their potency. And the duration of the intensive phase depends on the treatment with the injectable. That is how you treat the MDR TB. About the care of the hip, traction prevents or corrects the deformity, gives the rest to the joint, releases the muscle spasm, maintains the joint space, and minimizes the chance of development of migrating acetabulum. And the weight is 0.45 kg per year of age bilaterally. Remember, you have to give it bilaterally and not unilaterally. The hip mobilization exercises within the limits of pain. And then, of course, the hip spica is not used anymore now. It's very cumbersome. Even today, I'll use a hip spica in selected cases. If the joint is gone, there's a fibrous ankylosis, patient has pain, and the position is not functional, I'll take the patient to the theater under anesthesia and see if I can correct the deformity till it is in a functional position, and then put the patient in a hip spica. These days, I'll put them in a single hip spica, not the 1.5 spica, and let them walk on the good leg and keep the spica on for 6 weeks or so till the time the hip becomes stiff in a functional position. The surgery indications are inadequate response to chemotherapy alone, inadequate outcome of chemotherapy, painful or deformed joint, and advanced disease with unstable hip. The procedures are the joint debridement and synovectomy, arthrodesis, arthroplasties, and corrective osteotomies. The joint debridement helps in many ways. You can get histopathological confirmation of the disease. You can reduce the disease load, the organism load, the better vascularity. The synovectomy helps in healing drugs locally. It can help in the correction of deformity because the spasm is taken care of, because the joint becomes less pain, but you take care not to disrupt the retinacular vessels and not to dislocate the joint. And the curettage of cystic lesion and bone grafting can be done, wound closure and hip spica. And this is like what I said, for a stage where the joint is not salvageable. However, I would be more inclined to do a synovectomy in a joint where the joint is salvageable, hip movements are possible, cartilage is maintained. That would be a bigger indication for me. The complications are avascular necrosis, slip of the proximal femoral epiphysis in children, and the fractures. The hip arthrodesis is infrequently done procedure, but you must know about it. It can be intra-articular or extra-articular. You must know the different approaches and different techniques for doing that. And also the position of the hip arthrodesis is very important. It's usually a minimum of 10 degree or 1 degree of flexion every year of age, starting with a minimum of 10 degree and a maximum of 30 degree, which means in an 11-year-old child, it will be 11 degrees, and in a 25-year-old adult, it will be 25 degrees. You should give an external rotation of 5 to 10 degrees and no abduction or adduction. Contraindications to arthrodesis are uncontrolled active infection, degenerative changes of the lumbar spine, opposite hip or ipsilateral knee, or the arthrodesis of the other joint on the ipsilateral or contralateral side. Excisional arthroplasty is another way if the patient wants a mobile hip, but it's not exactly painless. It causes shortening and instability. It's a kind of pseudoarthrosis. Complications are infection and wound complications, unstable hip with lurch, pain after a few years, and degenerative changes in the spine. Replacement arthroplasty is aimed to give you a painless, stable, mobile hip. Prerequisites are preferably the joint should be quiescent clinically and radiologically, and there should be stable serology. These days, many people do MRI to see whether there's any disease left there, particularly if the patient has recently had ATT, but then you are best advised to not mention that unless the examiner probes you. So the summary for surgical indication is the clinically not responding TB, failure to obtain acceptable outcome after conservative treatment, and painful heel disease due to secondary osteoarthritis. If the patient wants painless, unstable hip, it is it's girdle stone. There will be movements which will be preserved. Painless fixed hip will be arthrodesis, and painless mobile hip will be the total hip arthroplasty. Just a few technical tips for total hip arthroplasty post TB. There has to be perioperative ATT, even if the patient has had heel disease for a long time. There's no consensus on duration. We started 2 weeks before and continue it for 3 months later if the disease is otherwise well healed. And then, of course, the flexion and internal rotation deformity needs the release of anterior capsule. Adduction deformity will need release of adductors, and osteoporotic nature of acetabulum has to be kept in mind while preparation. So timing of surgery is debatable. It's anything from 3 months after starting ATT to 10 years or more. And like I said, now more and more literature says that you can do it anytime you like, but then you must start them on ATT. Both cemented and cementless hips are good enough. And this is one illustrative case where there was, you can see classical tuberculosis picture, and tuberculosis can be a very useful option for these patients. So contraindications are chronic discharging sinus, significant medical conditions, skeletal immaturity, and other contraindications. This is one just a message for you that these days, because of the some of the patients who are on disease modifying agents for biologicals for inflammatory arthritis, they can have tuberculosis periprosthetic joint infection. In the same way, joint replacement done for tuberculosis can have a recrudescence anytime. This is a paper systematic review which has said that it can be done safely, but and gives you the technical details. You should go through it. And this is a paper which talks about the total hip replacement in acute tuberculosis from Korea. So to summarize, hip is the second most common site for skeletal TB. Hematogenous spread occurs from primary focus. Untreated disease passes through 4 stages. Girdles, the gene expert is the most important diagnostic test available, which is quick also. No consensus regarding regime of ATT. Total hip replacement can be done in cases of active TB, and recurrence of TB in total hip arthroplasty done for TB can be managed with chemotherapy. Thank you very much for your attention.
Thank you, Professor Rajesh, and for such a nice and elaborate presentation on tubercular hip. I request Dr. Vineet, you can have one question from the postgraduate for Dr. Rajesh Malhotra. Then he can go to his next lecture. Dr. Vineet.
Thank you, sir. Thank you very much for your nice presentation. Sir, you have specifically said that patient can be operated post-tuberculosis. And for the young student, we just want to know, there's any specific period? Earlier we should say it's a 5-year of post-treatment, or 10 years, or anything which can suggest us that now the disease is not active.
Yeah, so I think, let me put it this way. There is literature both about doing it at least 10 years after the disease has been healed, or doing it while the disease is active. Now, let me tell you what makes sense, a lot of sense to me, because there is, the PGs can safely say that there's no consensus. If the patient is not disabled because of symptoms, it is good to give ATT before doing joint replacement. However, if the patient is in too much, even if you are doing it after the disease has healed, you are supposed to give ATT in the perioperative period. So if a patient has an active tuberculosis, you will have to do it when the patient is on ATT, or if the patient has healed tuberculosis, still you will have to do it by putting the patient on ATT. So my take will be whether I can wait and give ATT so that the disease is controlled when I do it. But then people have published that total hip can be done even in the presence of discharging sinuses. So you can see the amount of confusion in the literature. So best thing will be, if it is possible for me to temporize and stall, I would like to give ATT and wait. If the patient is in too much of symptoms, maybe I'll have to operate before the patient completes the ATT.
Thank you,
Why
Professor
only up to
Rajesh.
3 months? But sir, why only up to 3 months only? Well, is there some criteria that it should be given only 3 months for post-operatively?
In a healed disease where the ATT has been completed, and it is now patient is healed, we are trying to take care of the recrudescence. So anytime we operate on these patients for hip replacement, at whatever stage of the disease, we take a biopsy. So we have a histological confirmation that there is still some disease or not. But because there is a risk of recrudescence, you are taking care of that by giving it for 3 months. There's little to be achieved by giving it beyond 3 months when you have seen intraoperatively, when the disease was already healed, the parameters were normal, you have inspected the joint, it looks healed, you have taken biopsy, which is all right. I think it's okay to give it for 3 months. We have not had a problem. Maybe we should publish it.
Okay, thank you very much, sir.
Thank you, Professor Rajesh. Professor Rajesh Malhotra has to go for a TV program after half an hour. So I request Professor Malhotra to continue with your lecture, and then we go for Dr. Gurinder Bedi's lecture. Professor Malhotra.
Thank you very much once again. I'm going to talk about non-union fracture neck of femur in elderly. And you heard Dr. Magoo, and he said if an old person comes, you just do an arthroplasty. So let me take a case for it. Let me make a case for it. So these are the learning objectives, and let's address them one by one. So the fracture neck femur, is a very common, in fact, the second most common osteoporotic fracture, and there are about 1.6 million fractures worldwide annually. What is a non-union? It's very difficult to define it. And then the definition varies from unoperated to operated. So people have said from 3 weeks to 6 weeks to 3 months as ununited or untreated if the fracture neck femur has not been operated. And today I'm going to talk only about the unoperated as the topic suggested to me. So we would usually take it about 3 weeks, especially in an elderly, where we have low threshold of doing the arthroplasty. The incidence overall for non-union for fracture neck femur is 20 to 33%, and undisplaced fractures it's up to 5%, and in displaced fractures it's 9 to 35%. You must always try to remember the anatomy of the neck of the femur as well as the vascularity. The capsule encloses the femoral head and most of the neck except posterior lateral aspect, and no callus is formed in the intracapsular part. We'll talk more about that. And then always remember, the femoral neck, scaphoid, talus, these are the areas where you must always remember the blood supply, as also the collateral vessels around the elbow and the knee. Now, there's an extracapsular arterial ring. The ascending cervical branches rise from lateral epiphyseal artery, 80% supplies because of that. Then there's artery of the ligamentum teres, and fracture neck of femur jeopardizes the lateral epiphyseal vessels, and then the intracapsular tamponade is the one which is the culprit. Now, the Dr. Sandhu has published a seminal paper on the staging or classification of neglected neck of femur. It will help if you study that. It is based on 4 factors which can have a mnemonic gaps. So gap between the fracture fragments, AVN changes, proximal fragment size, and surface of the fracture. And this is the chart which helps you to decide the plan of action for a patient who comes to you with a fractured neck of femur. Now, change in the non-union. The changes during non-union which occur include absorption of the femoral neck, which leads to reduced size of proximal fragment. The fracture surfaces become smooth, the fracture gap is increased, and there are avascular necrosis changes in the femoral head. There is thickening of the synovial membrane and joint capsule, osteoporosis, the upridden greater trochanter giving rise to limb shortening, and the quadriceps and the glutei wasting. The causes of non-union also, you must know the absence of the cambium layer in periosteum. There are certain cytokines in the synovial fluid which inhibit callus formation. The fracture hematoma is washed away by the synovial fluid, and there's a direct tamponade effect, so also interfering with blood supply. The history includes a definite history of trauma, unless it's a pathological fracture because of malignancy, the inability to bear weight, limp and shortening. There is external rotation, upridden greater trochanter, and adduction deformity. You should look for ASIS deformity levels. Many times these patients with neglected fracture neck femur, when they're lying at home, they lie down on the lateral position on the contralateral limb because the ipsilateral fractured limb is painful. So they very often develop a flexion, adduction, and internal rotation deformity, and even a flexion contracture of the knee. So beware of that, and also look at the knee if you are having a neglected fracture. There could be a scarpus triangle tenderness, though it's very uncommon in a non-union or a neglected fracture. And all of you must know about the Brandt's triangle, which shows the supratrochanteric shortening. The telescopy is quite likely to be elicitable in a resorbed neck. And of course, the Tenberg sign, which has been so nicely demonstrated by Dr. Sudhir Kapoor. There's a Dassault sign, which means that if you try to rotate the thigh, if the femoral neck is intact, the rotation will occur at the pivot around the hip joint. So the femur, the trochanter will rise from the bed. On the other hand, if there's a neck femur and you rotate, it will just rotate along an axis passing through the neck. The investigations include the X-ray, CT scan, MRI, DEXA scan for osteoporosis workup, and the DVT scan, as the patient can be immobilized for a while. And it is not infrequent for us to find patients coming to us when there's a neglected neck fracture to come with a DVT. So the X-rays should be taken. Recommended is the pelvis with both hips AP view, then involved hip with thigh AP and lateral view, and X-ray pelvis with bilateral hip 15-degree internal rotation. So you can actually skip the top one and just take X-rays with the internal rotation. That will suffice. Now the CT scan in a younger patient, when you want to do fixation or osteosynthesis, will be more useful to look at the morphology, and similarly MRI is more useful to see the AVN changes. But then in an old patient, if you have a strong suspicion of a pathological fracture, you may need it. Now the treatment is aimed at providing painless, mobile, and stable hip to the patient. And like I said, the replacement for the elderly patient is the treatment of choice, and let's see why. If you have a non-union of fracture neck of femur, with the pre-existing hip disease, this patient had a tuberculosis of the hip joint in the past and had a fracture, and 4 months back was bedridden, came to us with a hip which was arthritic, with a fractured neck femur, and avascular necrosis of the head, and a DVT. And obviously, there would be no controversy about doing a total hip because the acetabulum is already arthritic. But then, if you don't have a hip arthritis and you have a non-union in an elderly, not Dr. Maggu's patient group, there are arguments for arthroplasty rather than osteosynthesis, because you can mobilize these patients early. You don't have to put them through a restriction of weight bearing. They can immediately bear weight. The lower revision rates are there. The rate of reoperation following internal fixation of femoral neck fractures is relatively high. And the rates of osteonecrosis and non-union treated with fixation is very high. And then the relative risk of revision surgery after arthroplasty is relatively low, particularly in the old age group. So this is an article in Journal of Orthopedic Trauma, which showed that after internal fixation in patients over 50 years of age, there was a 21% reoperation rate. And only 67% of all fractures healed at 24 months, and 30% had fracture shortening of more than 5 millimeters. And you can understand that this is really not an option for an old patient. So this is a paper which says that elderly patients with femoral neck non-union, the acceptable revision treatment method is arthroplasty, right? There is no question about it. There is debate about THA versus HA, and I'll address that. So what about what to do? Unipolar, bipolar, total hip replacement, dual mobility. So let's take a look at it. The fracture neck femur occurs in a patient who has not had arthritis. So the capsule is pliable with age. In an arthritic hip, when you do total hip, the capsule is fibrotic and thick. So the risk of dislocation is very high when you do total hip in patients with fracture neck femur. So you have to try and give either a large head with a unipolar or an effective large head with a bipolar dual mobility or a large head total hip replacement. So hemiarthroplasty is used when the patient is more than 75 years old. Mind you, most of it is physiological age, and also sometimes this 75 can be made 70 years, but the patient should have an expectancy of not more than 5 years. So somebody who's 85 or 90, I'll have no hesitation in doing an Austin Moore, because that will be very quick. And the patient is unfit for osteosynthesis or THR, again, a quick surgery like hemiarthroplasty can be done. So what about hemi? Should it be unipolar or bipolar? There's no consensus, but then it is said that if the patient is older and only homebound ambulatory, then you can do a unipolar. If the patient, and of course, patient is less active or has shorter life expectancy. On the other hand, with the relatively younger elderly who are active, who are community ambulator with considerable life expectancy, you can take bipolar. There's a theoretical advantage of bipolar over unipolar, that there's a greater range of motion before dislocation, and the intraprosthetic articulation decreases the acetabular wear by shifting some hip movement. But there are a lot of studies which show that the bipolar, because of the serum and blood getting into between the articulation, can become a unipolar after some time. So this is an 82-year-old male who was treated with an Austin Moore, and this is a 72-year male who was treated with a bipolar implant. Now, if a patient can afford it these days, my first choice will be to do a modular bipolar, where if required, if there are any acetabular changes later on or issues with the acetabular side, I can go and take out the bipolar head and put in a total hip replacement. Now, the total hip arthroplasty is indicated if the patient's physiological age is more than 60, but the patient has high demands. And it is also the treatment of choice for failure of osteosynthesis of a fracture neck femur, or I know it's very rare, but if Dr. Magu's surgery fails, or if the acetabulum has orthotic changes. There is a very good functional outcome. There are a lot of literature till date, except for very, very recent literature and meta-analysis, which have showed that that only THA should be done, and most of it is from the European and the Western literature, because it causes less acetabular erosion. A lot of people say that it's an unphysiological articulation between the metal and the cartilage. However, there's an increased cost, increased magnitude of surgery. It needs more training, more inventory, increased blood loss, increased early dislocation rate. You have to be trained to do total hip replacement. And then our patients who are in district who get fractures, an average orthopedic surgeon can do a hemi replacement in a district hospital, but it will be difficult for him to do a total hip replacement. And above all, many of these patients we know die within 1 year. It will be too much of a surgery. So unless patient is very young, physiologically fit and demanding, you should consider it with caution. The treatment options, whether this whatever we are going to put in hemi or total is to be cemented or uncemented, is also decided by the DOR femoral bone classification. You must always know that. The A type is the champagne flute, and the C type is the stovepipe, and the B type is in between, depending on the size of the medullary canal and the thickening of the cortices. The advantages and disadvantages of both. The uncemented can be implanted very fast, and they are less risk of the thromboembolism. However, there is a reduced osseointegration, osteoporosis, and risk of fracture is there. The canal may be very wide, and there may be implant size mismatch, and there can be higher pain and less early mobility as per some reports. The cemented one has advantages that you have a relatively lower risk of fracture. It's good for osteoporotic bone, suitable for wide canal, lesser pain, immediate mobility, early mobility, but then there's increased duration of surgery, increased risk of thromboembolism, higher mortality, and also theoretically a higher risk of infection. So this was a 66-year-old female, good bone quality. It was reasonable, even if the neck was resorbed, it was reasonable to do a cementless total hip arthroplasty. So what are the surgical challenges? The bone is osteoporotic. There's a risk of intraoperative fracture. Up-ridden greater trochanter has to be brought down. So the releases have to be done. Adduction deformity may require adductor tenotomy. You have to pull it down to maintain the limb length. The cardiopulmonary complications during cementing. Offsets have to be restored as per the opposite side. And then, of course, there is risk of dislocation following arthroplasty. So choice in THA, like I said earlier, is effective large head to overcome the high risk of dislocation. This was when we were doing the metal on metal. So this was a non-union fracture neck femur treated with large head metal on metal. I would not do it now, but then there are still options like delta motion, which are large head ceramic on ceramic, which can still be considered in a relatively physiologically relatively younger patient. Now, this is what I want to tell you. This is a dual mobility cup. They come in both cemented and cementless versions, and they allow you to put a total hip and still have a large head, which allows, it's a tripolar cup, which allows movements at the two articulations, and that actually really is associated with a markedly reduced risk of dislocation. And this is my choice if the patient is affording for doing total hip in a patient with fracture neck of femur. Now, long-standing cases with resorbed neck sometimes need special options like a modular neck, and you must keep that in mind. And the post-operative rehabilitation is early full weight bearing to reduce complications. We must try to reduce the further falls at home. And then, of course, the chest physiotherapy, incentive spirometry, active quadriceps and ankle exercises, and maybe to some extent something like an aspirin to reduce the risk of thromboembolism. You must manage osteoporosis. You are failing in your duty if you treat a fracture neck femur without treating the underlying osteoporosis. That is absolutely a must. And you can treat, I would have a reluctance to treat them with teriparatide because that's a 2-year course. But then the options like bisphosphonate, like the zoldronic acid injection, is almost a rule in our setup unless they have the renal compromise. So this is a treatment algorithm. You can skip the upper side, which talks about non-union treatment with 3 stages described by Dr. Sandhu. But then if the patient is old, but physiologically younger patient, a high demand patient, you can do a total hip replacement. If the patient is more than 70, you can do an hemiarthroplasty. And this is how we choose between hemi and THA. Look at the patient, whether the patient is cognitively intact or at high risk of dislocation as a previous stroke or Parkinson's disease and all. So if the patient is cognitively and neuromuscularly intact, or he is not. If he is not, you should consider hemi rather than a total hip. If he is intact, then ambulatory and good life expectancy, you should go for total hip. If he is, doesn't have a very long life expectancy, you should go for hemiarthroplasty. And I'll finish this talk by this one paper by Mohit Bhandari's group, which was published in NEJM, and it should put a lot of controversy to rest, although these patients have only been followed up for 24 months. But this paper says that the total hip arthroplasty is comparable to hemiarthroplasty in a hip fracture. It doesn't offer much bigger advantage. The only catch, I think, is that a hemiarthroplasty fails because it either sinks in the femur, and if you cement it in the femur, it goes to the protrusio. Both the complications of hemi replacement occur because of poor bone quality. So if you are able to take care of the bone quality as well, You will see some of the hemiarthroplasty which are seen. You will see around you. Your boss did it 15 years back, and the patient is coming around walking and doing very well with the hemiarthroplasty. So that is the note on which I leave you. Thank you very much for your attention.
Thank you, Dr. Professor Malhotra. I request Dr. Gurinder Bedi to be ready with his presentation. Professor Malhotra, there are one or two questions from the audience. After
Yes,
how
please.
much time you start weight bearing in a non-cemented hemi and total hip?
Actually, we start weight bearing immediately, because if you, in these patients, if you delay weight bearing, much of the advantage of an arthroplasty is gone. And I did not go into the details, but some of the stem designs, like the double taper wedge design stems, there are studies which have been shown they are very effective in osteoporotic bone and they do not sink. I also showed an example where there was a resolved neck. There was a type of stem which was called bicontact. So it has got a flange which actually bites into the trochanter and is immediately stable. So what you have to do is you have to do a good cementless total hip. What I showed you the criticism was from the literature. But if you do a good cementless, you can make them weight bear immediately.
Professor Malhotra, there is a question that in Carey's hip, if you have to give traction, for how long do you give it? If
in
it is,
Carey's hip,
yeah,
so it will have to be anything between 3 to 6 weeks, because you will the purpose of the traction is to correct deformity, relieve pain, but you have to give ATT. You have to wait till that ATT has caused enough amelioration of symptoms. So I think it will have to be minimum 3 to 4 weeks, but may go on to 6 to 8 weeks.
Okay, thank you, Professor Malhotra, and we are very, very, obliged, and most of the viewers were totally spellbound with your presentation. And I had so much pressure because my this program had to finish at 8 o'clock, and I had to take a time till 9 o'clock. So there is a 1 hour extension, and there was so much pressure I could not do anything. Thank you very much. Thank you for being
very
with
much
us.
for watching.
And I request Professor Gurinder Bedi to come up with his presentation. Then we take questions. And if we have some time, we can take Dr. Sumit Suval's few gates are remaining. If we have time, we can do that. Dr. Gurinder Bedi.
Manish, you can see my presentation and you can hear me?
Yes, sir. Yes.
You are visible. Perfect. Wonderful. Okay. And thank you so much, guys, for staying around. It's good to have such an august bunch of delegates, very well organized topic. And hopefully you'll all learn something. At least I'm learning something sitting out here. But I promise I'm not sending you any glasses of beer after this, but hopefully you all have something in your hand to drink with. Yes. So what's the problem with intertrochanteric fractures? Well, there's not one. There are actually too many problems. One is that most of the patients are very elderly. The bone stock is very, very poor. There's a lot of comminution at the fracture site. The patient compliance as regards mobilization is very poor. So you can't really give them instructions like partial weight bearing, toe touch bearing. Most of them will take the weight just as they can because they're not able to balance themselves. And there's a hell of a lot of weight which goes through the fracture site, and there's a lot of force which happens. And you can't really reduce it. Even things like an SLR moving the hip across to the bed actually causes a lot of weight to go through. So malunion definitely happens very often, and it does cause fair amount of issues. Remember, implant failures are not that uncommon. So a host of problems which are there, but not to be in total despair. There are a few good things about intertrochanteric fractures. One of them being is that the vascularity is rather good. The patients are normally not as demanding. So you'll get away with murder in quite a few people. And union, remember, is fairly common. So it's unusual to get malunion, to get a non-union. See the incidence out there? It's just under 5%. So it's 2 to 5% what is reported. But the incidence of malunion is quite high. Now, just have a look at the slide again. So the overall complication rate remains about 20%. Remember, as Dr. Malhotra said, 1/3 of them are almost going to die within a year. So you really need to make sure you do one surgery, do it well, give them back whatever quality of life they have. And implant failure rates are very, very high in this kind of a thing. So the reason why you get a lot of malunions is the amount of muscular force which is there. So I know I'm showing a photograph of a subtroch fracture, but the forces are fairly similar in both. So it's the gluteus which are going to abduct, the iliopsoas which is going to flex and rotate rotated externally. Then you have the short external rotators which are again going to cause a rotational element of stress to the trochanter while the head remains in position. So whether you treat it non-operatively, operatively, the forces are going to be the same, which need to be counteracted by whatever you do to it. So these are the kind of X-rays which you're going to see. So you can see the amount of shortening which is there. You can see the foreshortened appearance. The trochanter is actually gone behind the neck. The lesser trochanter is quite prominent, just showing the amount of external rotation. And this is what happens even though you've actually reduced it well, you fix it well. Look at the amount of resorption that is happening. So pretty much this is what happens, and that's what you get malunion happening at an incredibly high rate in this. So what you're going to end up with is limb which is shortened, the limb which is externally rotated, and the hip which is in varus. So whether you treat it operative, non-operative, obviously I think most of you know that operative option is the way to go. The limb can be short by a little bit or a lot. They can be varus. And most of the patients, as you can see on the photograph on the right, will keep their legs externally rotated. So the biomechanics happening because of all of these. There's an altered rotational alignment because the hip is gone to external rotation. There is a coxa vara, and remember the offset is decreased now. So the offset decrease is going to cause a reduced abducted efficiency, which I think we've gone over this now even in the past few presentations, is going to cause the difficulty in walking and standing and early fatigue. So people will tend to get tired out. Once they've done a little bit of walking, a little bit of standing, they'll tend to tire out a bit. I don't have to go over the diagram again with you, but just to tell you that the problem you're going to have there is what this lever arm, and this is going to remain constant. What you're going to be having is a smaller lever arm and the abductors which are not actually acting through their normal length. So it's a shortened out length of the abductor, which makes it more inefficient to move. So in all, this element is going to give you a Trendelenburg element, both in the gait and a Trendelenburg sign, which is to say that this hip is not going to be operated. So as you can gather from the past talks that you had, you're going to get a Trendelenburg lurch, a Trendelenburg gait, and a patient will be limping from side to side. So when you come to do a clinical examination, when you're looking at the gait, you're going to have a combination. Remember, we just gone over that. Trendelenburg with a short limb element. You got shortening and the abductor insufficiency. When you see the patient standing, as we've just been told, you got to look at the shoulder and the patella level for the level of the scars. When you ask the patient to sit, remember LLD is what you're looking for. So you can have a look at the Galeazzi sign. You can do it sitting, you can do it lying. But both ways, it's the same thing. When you do an examination, lying down and you have a look at it, obviously you're going to look at the attitude of the leg. And the leg, as I said, will be externally rotated, and you're going to have some amount of shortening, which you can see, and it's going to be a true shortening. And remember, you got to actually measure the amount of shortening which is there. Do comment on the level of the patellas both, and look at the surgical scars in the present age. It's unlikely to see a patient who doesn't have a surgical scar somewhere or the other. After normally the range of movement is reasonable, provided that he's not gone to a non-union. But the arc of movement can be actually different because of the external rotation, the internal rotation can be either not there or very much reduced. But the amount of external rotation will almost sort of maintain the arc of the movement. When you come to do a special test, the Bryan's triangle, which is going to do the show you the shortening is going to be altered because the equilateral triangle will not be formed. Another thing to look at is the torsional profile. When you look at the torsional profile, you'll have to distinguish whether it comes from the tibia and the femur. I'm talking about a normal case. So if you have whole limb, you can look at the foot progression angle, which is shown in this. When you draw a line, 1 foot goes out, 1 foot stays in. So you can have an outgoing and ingoing, and obviously it's going to be asymmetrical. When you look at the femur for a rotational malalignment, you can have the prone test, in which you're going to have a look at the internal and the external rotation. And depending on the movement which you've lost, you can actually see which way is the rotational malalignment. If you're just looking at the tibia, this is more for the sake of completeness. Then you actually make the patient prone, knee flexed. Look at the long axis of the thigh, long axis of the foot, compare it to the opposite side. So here you negated the femur out totally, and you can only have the tibia, which can actually give you this kind of a problem. So is this been proven out in literature? And very much so. So most of the literature will tell you about the high chance of abductor weakness, and also that it takes a long while to actually get better. So who gets it? Who gets it more? Who gets it less? And the answer is, the older you are, the higher the degree of comminution. The treatment modality, whether you put a sliding screw, whether you put some screws in, or you've done a PFN, actually makes a difference. And you can actually show that the intramedullary nail ones have lesser chance of collapse compared to maybe a sliding hip screw. The stability of fracture hence comes into force. And if you look at the OTA classification, these are the ones which are much more likely to have more significant shortening, more malalignment, and cause you more problems. The other thing to look at predictors of malunion would be what is happening to the posteromedial aspect, which has been well looked in the literature. So that's a posteromedial fragment. There's a look from the back. So the size of the posteromedial fragment, the amount of comminution which is there. Another way to look at it is what is the thickness of the lateral wall. That's Gottfried's article, which I'm talking about. A good article to reach would be the George Hadukovic article, I think is 2009, which looks at the 10 tips to improve the result. So now we come to the solution. Now we know that we have a malunion problem. So who do you have to approach aggressively? Who do you approach gently? The answer is, look at the functional impairment. You'll be very surprised how some people are managing so well. And remember, it takes a while to recover from this. So don't rush it. The younger demanding patient, obviously rush in. If he's already having a collapse, he's going to do badly. Definitely get in early and try to do something about it. So this is an 82-year-old Sikh gentleman, comes from Punjab, walks into my clinic, and I look at him and he tells me about this pain, and he has this very vague kind of an history. And I almost thought there's nothing wrong with him, but then I just thought, there wasn't, the comparison of the two legs was showing that both of them had the significant leg length, both had a significant external rotation. I just thought, oh, I should get an X-ray. And there you see it. I mean, this guy's kind of walking in. So he's compensating for his malunion because he's matching up both the sides. So there was no point really offering him anything. And I said, look, you're doing too well. I don't think I can make you any better. So when you have to come to think about an operation, you're going to require, as Dr. Madhu said, something like a valgus osteotomy in the more younger one. Remember, the head and the neck is much more likely to be intact compared to the non-union neck of femurs. So this is actually easier option. Remember, union is not that much of an issue. So a valgus osteotomy may be more better out here compared to, say, a neck of femur. So you have much better results with this. But you would consider hip replacement, obviously, in the very elderly, the very old kind of stuff. Remember, we'll check the re-rotation. So you might have to dial an element of rotation into it. And there are lots of things giving up. You had a much better person talk about it, so I'm not going to go. Just to say, you need a torsional profile, which you can check, or you can do a ballpark figure of rotation or something. So how do you do it? You can do it with a DHS, a simple DHS, a 130-degree DHS can actually do the job for you. You can also do it with a blade plate. You can also do it with a double angle. So there are lots of options for doing this. So here's one case which was done earlier by one of my colleagues. So you can see that non-union, the patient was offered, very elderly person, patient was offered an operation. He didn't want the operation of a replacement. He said, do whatever, but I'm not going to have a replacement. So this was done. And again, may I say, and I admit to it, not fully well done, really. And then eventually it collapsed, and he was never really a good candidate, given not all of his other medical issues. And that's what he ended up having. But, you can actually intervene early depending on, so that was one element that you need to look at about quality of bone, how good you are at doing these things. So the other thing, decision making, is who requires an early one, who doesn't require an early one. So what I would say is, say somebody like this who walks in at about 2 months, the implant is holding on, and you know that around 2 months he's likely to be healing, he's slightly on the elderly, that's not the time to get in. You can actually let him walk on it and see if the pain settles down. So maybe you don't have to do anything about it. So this man, I would rehab it at this stage. But look at this guy. He's about 33-year-old. He's had a fall down the steps. Somebody's gone ahead and put this nail inside. But immediately you can look at it. He's obviously got a coxa vara. He's already got a shortening. He was told to wait it out a little bit, more bed rest, more slow walking and everything. So when he comes back to me at about 3 months, now at this stage, his fracture should be on the verge of healing. I can't really see the point in operating him now. He's just started to walk. So in my opinion, I would have said wait for the time being, but I've told him he's very, very likely to, his socioeconomic status is likely to, very likely that he will need a valgus osteotomy because he's that young. This kind of a thing in implants, walking out, you need to do it as early as you can. So this is somebody who's about 72. So he's been walking using a walker, cannot actually get better than this. Now this guy needs a proper valgus osteotomy. That's what it's done. And it seemed to heal up in no time and got him
Dr.
walking.
Gurinder, 1 minute more, please.
That's wonderful. So we'll be done. So this kind of a thing in the implant is cutting out through, it's eroding. A total replacement makes a lot of sense. Lots of literature to look at if you want to look at and follow up and the results and everything. And also a lot of literature to talk about how the amount of collapse has a direct bearing on the physical functioning, social functioning, and a huge thing. So this, if you really want to know how bad you can get, this is a great paper in Journal of Orthopedic Trauma. Essentially, it shows us your gait is totally altered once you get this kind of a thing. To summarize, it's a fairly common thing. You got to pick the unstable ones and preferably do a nailing. Not all malunions will require a treatment. So who requires a treatment is an assessment you need to do for the patient. But whatever you do, mobilize them early. Thank you so much.
Thank you, Dr. Gurinder. And we have 7 minutes for questions. So it is open for all the faculty. Dr. Vineet?
Yeah. Sir, one question for both the senior faculty. I think we were getting two senior persons with two different opinions, whether in an old neglected neck femur, whether to preserve the hip or, yeah, can you hear me?
Vineet sir, please remove your finger from your pad.
Yeah. Am I visible? Yeah. Sir, are we getting a clear message for the students, whether in an old neglected neck femur, whether to replace it or preserve it? Still the PGs are confused. What is the take-home message for them?
Can I say something here?
Yes, sir.
This is Dr. Sudhir Kapoor.
Yes, sir. Please boliye.
Can I say something?
Yes, sir. Yes, sir.
Please, you are audible.
Yes, let us be very clear. Let us be very clear about one thing. We are talking to postgraduates. Personal opinions, personal experiences should not count here. As far as the PG is going for an exam is concerned, elderly patient, non-union, replacement. There's no question about that. I don't think as an examiner, I like to, I mean, if a candidate says to me, when the examiner, elderly patient, I'll do arthroplasty, no further questions asked.
Am I audible?
Yes, sir. Yes, sir. Dr. Maggu, please.
I emphatically said for the postgraduates, elderly patient, arthroplasty. And I agree with Dr. Kapoor. I have already emphasized elderly patient, a resident will say, sir, I will go for arthroplasty.
I think there should be no confusion.
Okay.
No confusion about this. Both of them say the same thing.
No confusion about it.
So message is elderly patient, arthroplasty, and younger patient, we can go for the preservation of the hip.
Yes.
Right? Yes. So that's good.
Any other question from the faculty? It's an open house now. Anybody can ask question to anyone. We have 5 minutes. Dr. Sharad?
I have a question for Dr. Sural.
Yeah.
My PGs are asking, there is an age-old question that to be in which hand to hold the cane, in hip pathology or knee pathology.
Okay, thank you for the question. I think for that, I already explained in the biomechanics. I'll just go back to my slide share. Just a second.
Sural, I think it might be a good idea if you not only talk about hip pathology, but also knee pathologies. So it'll actually give you a better answer. And even,
well, actually, the thing is that I was given 15 minutes time.
I know, no.
Pathology.
You done a wonderful job.
Videos. Yeah. So I don't have the videos for the knee, but let me first answer the question. Can you see my screen? Because I don't know.
You need to do a screen share,
Yeah?
boss. Share screen kar.
No, I did a, just a minute. I don't know why the screen share is not coming.
Sir, first minimize your zoom.
Minimize zoom, open your presentation.
Yeah,
Yeah. Screen
Yeah,
is it
yeah.
there? Okay.
Yeah, it's coming. Yeah.
Yeah, now it's visible.
Okay, okay. So, how do I now?
Slide sorter. Sumit, नीचे जा slide sorter में देख. वहाँ से you'll find your slide. नीचे.
Yeah.
Yeah.
So, I was here. So the question was about the, should I skip all this?
Yeah.
Okay. Yeah. So this is the question which was asked.
Yeah.
So when we use a cane, like we were talking about cane in the opposite hip. So there are various things. First is a very logical thing that from the physics we know that the more is the base, the better is the stability. So the center of gravity is now between a larger base. Okay, that is a very basic thing which no book describes about. Now the second thing is when you are using a cane and you're pushing your hand over it, right? So the force which is transmitted through this cane, the effective load of the body weight is reduced because the turning moment around the femoral head. You see, when without this cane, the body, as I said, this is 66%, and then this weight of the limb. So this is making the body turn this side, right? So the turning moment is reduced, right? So the ground reaction force, okay, when it goes back, Powell has calculated that if you put 9 kilogram weight over this, then there's a 40% reduction of the load, right? So effectively it relieves the hip pressure because the ground reaction force is now going back in this direction and decreases effectively this body weight lever arm, right? So the abductor lever arm, abductor muscles don't have to work so much. The demand is reduced. Yeah. So is that clear about this question?
Yeah.
And what about in knee pain?
Knee.
Yeah. So knee is completely different because this is the biomechanics of the hip is based on the fulcrum in the center and the class 1 lever. In knee, we are not talking about the this hip biomechanics. So in knee, it is basically osteoarthritis. You can take the cane on the same side, right? In the osteoarthritis, but in the hip, it has to be opposite side. So knee.
Can I just
whether the varus or
is
there? Yeah, sorry.
Yes, I am there. Can I say something?
Yes, please. Yes, sir.
Yes, sir.
I'll reinforce what Dr. Sumit has said with a video, which I had shown my presentation. Probably didn't get register. If I am able to, is it visible? My screen is visible or no?
No, I'll have to say stop share first.
Sir, please unshare your screen.
I'm doing stop share first. Yeah.
Yeah.
Now you can put.
Sudhir sir, please share now.
Can you see it now?
No, not yet, sir. Not yet.
No, sir.
Let me. Okay. Fine,
So
sir.
minimize your zoom first.
Okay. Is it visible now?
Not yet, sir.
Okay, give me a minute. Things will be very clear now. Let him. I'll share screen, minimize the zoom.
First, minimize the zoom, sir.
First, minimize the zoom, sir.
Then open the PPT, then share it.
Hitesh, you want to take any more questions while Dr. Kapoor is setting it up?
Yeah, Gurinder sir.
Any questions?
Manish sir, I have messaged you. Please ask those 2 questions till by then.
Okay, I'll just see.
Can you differentiate radiologically between a monoarticular rheumatoid and monoarticular and TP hip?
Dr. Dhawan, can I make a comment?
Yeah, sure.
Just I want to ask the learned faculty, is it not too much to label a fracture as a non-union at 3 weeks? I mean, you can't call it a delayed union or something, but it's too early to call it.
Sir, but actually that was in context of fracture neck femur, I suppose.
Yeah.
It was. I think it's there are 1 or 2 papers which
Your screen is coming now.
Just can't understand the 3-week concept. I agree. I mean, who's going to start calling it a 3 weeks?
Sudhir sir, your screen is visible now.
I think better term would be an ununited fracture.
But a delayed fracture.
Better term would be, yeah.
And I would like to comment upon this a little bit, that it depends upon the fracture configuration. If the fracture is such that it is not going to unite, right, because the Powell angle, displacement, or whatever it is, then that's why those literature has come up, probably why at 3 weeks they are started to defining them to as non-union.
Now please see this video. Hello.
Yeah, screen is visible, sir.
Okay. Now please let the PGs see this video. Things will be clear. This is an example of a assisted tendon sign. Patient has a disease on the right side. When he's standing on the left side, no problem. Now please see when he stands on the right side, the disease side. When he stands on the disease side, he puts lot of pressure with his left hand on the clinician's right hand. He needs a stick on the left side. Is it clear?
Yes.
Quite clear, sir.
Okay.
See it once again before I close. Normal hip, no problem. Now diseased hip, right hip is diseased. See the left hand of the patient. He requires cane on that side.
I think let me clarify this. Actually, this is an assisted Trendelenburg test, and if you read it in detail, it is given in Apley's textbook also. So basically, it is what is happening is that when he's standing on the affected side, there will be a tendency to lurch on that side, right? We explained why it always lurches on the same side. Now, Apley's book says that when you tend to lurch on the same side, if you prevent that lurching, okay, it actually says you keep a hand towards near the arm and the shoulder to prevent that lurching. Then if you do that, then you find that he will apply pressure on that side, prevent that lurching.
Yeah, sir, we have to conclude the meeting because almost.
Dr. Manish?
Yeah, sure.
Dr. Manish, can I say something?
Yeah, sure.
See, as Dr. Sudhir has pointed out, to prevent the fall of the pelvis on the healthy side, he will keep a stick in the opposite hand. Please be clear with it. For a Trendelenburg gait, since the pelvis falls on the normal side, so to prevent that fall, he will take the stick on the opposite side.
Yeah.
It's important, not on the same side. And
yes,
whether it is an intelligent gait or it is a Trendelenburg gait, stick has to be in the opposite hand.
Sir, both for the hip and knee.
No, don't confuse the postgraduate. The symposium or the hip.
Okay. Now, see, my limit has increased to 1 hour. Now I cannot extend the time, and we have to conclude it because I still have pressure that please keep on continuing, but we can't do that. I thank the whole faculty for this such a beautiful hip symposium. I especially thank Dr. Ashok Sham for giving us this opportunity and this line to transmit it live. And our viewership has been more than 5,500. So it's an amazing thing that all over India the postgraduates have seen. Now this whole lecture will be on the YouTube also. So anytime any postgraduate, or he can go to OrthoTV website and he can see the presentation. So it will be there. So next symposium we will have on spine, and that will be next week. I will announce it. And I also thank Dr. Shamsul Huda for his technical support, Dr. Ravi for his technical support, and Dr. Vineet, you are raising hands.
Sir, I just want to thank you for that. It is not only India, it's abroad also. Few of my residents who are settled outside India, they are also coming.
But I am getting messages that please do not stop. Please do not stop. What to do?
I know. Same thing here also. But well done.
Very sincere thanks from Delhi Orthopaedic Association to you and the whole for arranging such a wonderful program.
Sir, I am very thankful that you have given umbrella of Delhi Orthopaedic Association, and I personally feel this should continue all over the year. And thank you, Dr. Dhananjay, for being with us. Yes, Dr. Shamsul, the last comment.
Thank you, Sarah, sir.
Dr. Shamsul, we can't hear you. Dr. Shamsul.
Can I say a word, Manish?
Yes.
I think basic advantage of this PG webinar has been we had such senior faculty. Those people who have been taking exams on regular basis, they have been able to provide such an insight into the HIP examination and the answers which the examiners are going to ask. That's the beauty of this webinar. I'm pretty sure all the students, all the people who are watching it, they have become wiser and they'll be able to do well in their exams.
Definitely, sir. Definitely.
Thank you so much.
Dr. Shamsul, you wanted to say something?
Dr. Shamsul, your voice is not coming. Just unmute yourself.
Dr. Shamsul says that we can have 2 or 3 more questions. So he has allowed us 10 minutes more. So
Manish sir, I have messaged you 2 questions. Just please ask to the learned faculty from.
I'll just find out.
Yeah, please.
One question, that patient has history of pain 6 months but has history of steroid intake for skin disease. What would be my my history taking that steroid intake to be included in the present history or the past history or the treatment history?
Lalit sir, please.
Lalit, Dr. Mani.
The present history you'll take.
In the present history. So this is one thing, and there is another question for Professor Maggu, but it because Rajesh Malhotra sir has left, says that patient had history of fracture neck femur 5 years back, operated and was absolutely fine, developed pain in the hip 6 months back, and chief complaint would be pain 6 months of fracture neck femur 5 years back. If the pain 6 months, where do we conclude the fracture history under the present or the past history or the treatment history?
What is the age of the patient?
He has not mentioned the age. You can say
Is very important. 5 years old neglected fracture. I don't think the status of the head of the femur. Or the trochanter has gone very high and created a painful bursa. There are so many causes of pain in such a situation. And I think examination is very important for such patients. It is a hypothetical question, actually, I should say.
And Dr. Vineet, any other questions from the postgraduate? Dr. Vineet?
No, sir. I think they are more than sufficient.
Dr. Hitesh, you want to say?
Yeah. Can the learned faculty, I have a question from PGs. Can the learned faculty elaborate on what is the exam diagnosis, exam definition, clinical definition of ankylosing of hip? When should they define the case has got ankylosing? Clinically,
junction. Pain in the
Can I answer that?
In third decade, young adult comes off on pain in the neck also, limited movements, I think, rotation particularly limited, kyphus spine. So I think all these are features and clinical examination that you can go in favor of ankylosing spondylitis.
Ankylosing.
No, his question is fibrous ankylosis of the hip. When do you call it a fibrous ankylosis?
Some range of motion, but painful. In fibrous ankylosis, it's always pain. Painful restriction of movements. Just jog of movements, but painful. It's fibrous ankylosis. In bony, there will be no pain.
Can I make?
Yeah. Professor,
Hitesh, you have asked me what do you mean by ankylosis of hip? Is that the right?
When should he say that is clinically that is an ankylosing of hip? That question has come.
Ankylosis is absence or near absence of all movements of hip. Absence or near absence of all movements of hip joint is ankylosis. If a jog of movement is present, which is mostly painful, fibrous, if complete absence of movements without pain, bony ankylosis.
Can I just add to this?
Yeah. Sure.
Okay, so basically, if you look at the definition of ankylosis, it is basically loss of movements of a joint. Now, if you read S-DAS, it's written there. So you have true ankylosis and false ankylosis. So false ankylosis is even a skin contracture, burn contracture. right? So the main question about ankylosis. So now the question is about fibrous ankylosis and bony ankylosis, which has been answered by Dr. Kapoor and Dr. Magoo. Bony ankylosis is complete loss of movements without pain, clinically, no tenderness. And fibrous ankylosis is a global restriction of movement, okay? But there is pain and there will be tenderness. Now, however, in India, a lot of patients do continue to have so what happens is they try to stretch the long fibrous ankylosis of flexion. So some of these patients, if you examine, you find that rotations are completely absent, abduction is absent, but there's a little bit range of flexion which is stretched out because of their habit of squatting. So that is the scenario of the long fibrous ankylosis.
Okay, last question, very important question. The role of traction before surgery in a neglected neck of femur fracture. Dr. Magoo, please.
Please repeat the question.
Role of traction before surgery in a neglected neck of femur.
Yeah, if there is too much of overriding,
okay,
then you can give traction for about 7 to 10 days to bring the trochanter down for about 10 pounds of weight.
Okay. So I think with this closing remark by Dr. Magoo.
Yeah, Sunita, please.
Yeah.
Can I add something, Manish, last?
Yeah, sure.
If telescoping is present, traction will not be of much use. If telescoping is not present or minimally present, traction will help.
Okay. So with this remark, I really thank everyone and the whole faculty and President DOA, Secretary DOA and people from DOA, Dr. Professor Lalit Mani, Dr. Sudhir Kapoor, Professor Magoo, Dr. Gurinder Bedi and Professor Rajesh Malhotra. Rajesh Malhotra actually was so busy today that he had 3 TV programs, but he made sure that he came to our DOA HIP symposium. So I really thank you, and we meet next week for the spine symposium. Thank you very much.
Thank you very much, boss. Thank you. Keep it great.
Thank you.
Thank you so much.
Thank you very much.
Thank you, sir. Thank you.
On behalf of faculty, I thank you, organizer and DOA.
Yeah, sir.
Thank you.
I'm really, I'm so happy with the viewership that, and I was made forcibly to extend time. And Dr. Ashok Sham, he was,
My thanks to Ashok Sham.
Yeah.
Asked me for this video conference.
Thanks from DOA side also.
1.5 year back, I could not do that. So I'm grateful to him, grateful to Hitesh also. I am able to see him, and Vineet and Sham again, Professor Rajesh Malhotra, all I'm grateful.
Thank you, Dr. Sharad.
Thank you.
Thank you.
I thank Sharad also.
Yeah. Good night, everyone.
Good night, sir.
Good night.
Good night.